We'll start out with a roll call. Albert, do you want to start us out?
Albert Wong, professional member.
Lavanza Butler, professional member.
Ricardo Sanchez, public member.
Stan Weiser, professional member.
Amy Gutierrez, professional member.
Debbie Thiel, professional member.
Victor Law, professional member.
Alan Shad, professional member.
Okay, we're going to go back on the agenda from yesterday, continuation, and we're on item 14, which is presentation on the board's pharmacist recovery program. Good morning. So I'm going to ask the board members if we could hold questions until the end, and then we can ask any questions we may have from the presentation.
Good morning. Thanks for having us today. I'm Ginny Matthews, or Virginia Matthews. I'm the project manager at Maximus. And I have with me today Stephanie Trum, who's one of our clinical case managers. Stephanie is not assigned to the pharmacist recovery program, but she's a certified addictions RN. And I invited her to come and speak about just an overall picture of substance use disorders and the impact of that on healthcare professionals and what it means to us. So,
Sorry.
that's okay. You saw a familiar face, huh? So Stephanie, this is, oh, well. All right, I'm going to jump ahead for just a second, come back to that slide. Our topics of discussion today, we're going to talk about the signs and symptoms of substance use disorders. You know, that's a change in the language. We've moved away from addictions and chemical dependency, and the DSM-5 now refers to it as substance use disorders, and it's a spectrum. So we're going to talk a little bit about that. The signs and symptoms and impact of mental illness and co-occurring disorders in the workplace. What is the Pharmacist Recovery Program? That's the program that you so graciously support. So we're going to talk about what are the signs and symptoms, the roles managers, colleagues, family members, individuals play in living with and working with people with substance use disorders, because it really does impact everyone around them. And the signs of diversion of medications in a healthcare setting, and the history, mission, structure, and components of the California Pharmacist Recovery Program. And then we're going to talk about when our pharmacists do return to work, the role of the worksite monitor. And we'll talk about it more globally, what it means to return to work and how that happens for us. So I'm going to flip back to that photograph there and turn this over to Stephanie.
Okay, I don't know if I'm on here. Okay, thank you. All right, thank you for the pleasure of being here today. My last name is Trum, and there's no P with that. I'm also a licensed advanced alcohol and drug counselor, and I'm privileged to be here today. I'm a psychiatric nurse and kind of always live a little on the edge. We do things a little nonconformist, shall we say. And just for a moment, I'm going to invite you to consider closing your eyes for a minute and going with me. Just think about how the state of California suddenly comes up with money and says, if you sit through this presentation, you get a $100 gift card to go to the mall today, but you have to spend it today. So you get off of work and it's actually still nice outside, and you go to the K Street Mall and you spend $100. It's starting to get dark and you're going back to your car. And suddenly you're aware that there's an addict following you. So it's getting dusk and you're looking for your car, and you're walking a little quicker, and these footsteps behind you are a little quicker. And suddenly you find your car, you're fumbling with your key fob, you open your door, you throw in your packages, you lock your door. Okay, open your eyes, please. How many saw a pharmacist behind you? How about a labor and delivery nurse? What gender did you see? This guy, yeah. Was the gentleman in a three-piece suit? Or was he in a rumpled outfit? Was he cleanly shaved? I'd like to talk to you about the reality versus the perception. Maximus has the privilege of serving 8 of the licensing boards, as you can see. When it comes to substance use disorders, there are many, many people who have mental illness and or substance use disorders. Nobody asks for mental illness, and nobody asks for a substance use disorder, whether they have professional letters after their name or not. 1 in 5, and this may be underdiagnosed in our nation, 1 in 5 adults with some type of mental illness in the past year. That's a lot of people who are suffering. And some of them also happen to have what we used to call addiction or a substance use disorder. I want to bring that up. What's interesting, in the healthcare professions, the numbers are higher. Generally, any study will suggest somewhere between 10 and 14% of the general population having some substance use disorder. With healthcare professionals, it can be as high as 1 in 5. That's a scary thought, because pharmacists aren't immune, nor is any other healthcare professional. And one of the reasons why there's a need for a comprehensive program is because the national centers will let us know that in the first 4 years, generally 90%, up to 90% of people relapse. But if they're in a treatment center and a treatment program that is extensive and also strength-based, along with accountability, people do much better, as you can see from the statistics for us. I don't know if anybody has ever had the occasion to experience a computer virus. So not fun. You put something in and you get something else out. And one of the issues with a substance use disorder is that it works in the brain very much like a computer virus. What goes in is what one thinks is predictable, but something else comes out. I consider a substance use disorder to be like a terrorist. It hits good people and they don't even see it coming. It takes everything precious away from them before it kills them. And fortunately, there's hope and there's help. But when people are in that very dark place, desperate people can do a lot of desperate things. So I just want to bring that up. It is known as a brain disease. The American Medical Association has listed a full diagnosis for substance use disorders. We know the etiology, we know the clinical pathway, and we know the outcome. And so this is much different than moral character issue. Nobody asks for a substance use disorder. It's interesting, they've done a lot of studies at the National Institute of Drug Abuse, and they find that for some people with the PET scans, those are the heat-activated scans showing activity in the brain, that for many, they will respond differently. For instance, somebody who may have a genetic connection with substances such as central nervous system depressant, like opioids. For most of us, the thought of feeling a little bit out of it and constipated is not very attractive. But for some folks, they get a paradoxical response when they take a Norco or a Percocet, even after a surgery. Rather than feeling out of it, they feel energized. They feel suddenly confident. So it is a mechanism in the brain where the neurotransmitter dopamine, that track, works differently. And the problem is, you cannot predict that. When you see a newborn, you don't know if their brain is going to be one who responds in that way. So many people think, whether it be alcoholism, opioid dependency, stimulant dependency, some people think, well, they just need to stop drinking. They can't hold their drink. You know, how bad of them? Nobody asks for a substance use disorder. And there's some research that suggests that alcohol type 2 on the genetic side of the male, where you'll hear about first time somebody takes a drink, they don't stop. They get sick and they throw up and all this and have a horrible time, and then they go right back to it. And one thinks, well, this isn't logical. There's nothing logical about a substance use disorder. It is a brain disease. Some of the changes can cause permanent damage in the brain. So I just want to bring that up because it's hard to understand, because you can't take a lab other than a breathalyzer often to look at what is causing all of this. It negatively impacts all of us. Increased health costs, loss of productivity, crime, auto accidents, premature deaths, all kinds of things. Interesting enough, there was a study that just came out last week that talked about there are more auto accidents now with DUIs with other drugs other than alcohol. Very, very frightening in our nation. We need to pay attention to that. Now, 2 key factors when it comes to pharmacists. By the way, just heard an interesting quote. Pharmacists and pharmacy students are not expendable commodities. They are worthy of respectful, comprehensive, research-based treatment, just like any other individual, so that they can then do their part to help someone else. I'm going to add another key factor there: attitude, accessibility, and stress. There's a little bit of stress in being a pharmacist these days. Healthcare professionals, we are all susceptible to a substance use disorder because of what I call the bionic delusion. We think somehow we're immune, and we handle these substances on a daily basis. We see the effects, and somehow we don't connect that we could be just as vulnerable. The pressures of working in any healthcare field today is much more intense than even 5 years ago. Plus, from day one of any healthcare professional school, we are taught to think outwardly, to help the patient. Most of us don't have a clue about taking care of ourselves. And if we do at all, it's, go to the gym. Well, that's good. That's not all it is. When a healthcare professional has a problem and they cross a line and they take medication that isn't theirs, they are in extreme need for help. They are at a point where they cross that sacred trust of patients, and they are very, very desperate. We've had some folks who don't make it to us. We have some who have gone in the parking lot and tried to suicide. There are incidents of healthcare professionals found in staff rooms who are blue, who die in restrooms, in very tough areas. Desperate people do desperate things, and the denial is huge because we're so busy taking care of someone else. Some people use to just keep going. So the invulnerability or the bionic delusion, unfortunately, is in the culture of healthcare professionals. My sister's a clinical pharmacist. I have huge respect for the pharmacists. She works day and night. She will go pedal to the metal on behalf of her patients, as will I as a registered nurse. Why? Because we're those kind of people. But the problem with our culture is there's no stopping point sometimes. When somebody shows up or gets called in sick and no one's to cover, the pharmacists will keep going. So there's a lot of stress. There's physical stress and there's emotional stress. And for some, happy hour is a way you let down. You go together as a team to debrief. And our culture really condones this, sadly. This one's scary. This says it's a nurse thing. It is not a nurse thing. but the culture is that it is.
That one popped up on my Facebook feed about a month ago, and they're for sale. You can buy these sweatshirts with different healthcare professional focus.
Yeah, we didn't order any, but yeah, it is also frightening these days where students, pharmacy students, nursing students, medical students are messing around with recreational opioids. This is an interesting slide. Take a look at it. Fentanyl, as many of you may know, 50 to 100 times more potent than morphine. And it kills good people, including pharmacists. Yeah, Ginny, as indicates, you probably know about the Sac County episodes recently where hydrocodone was on the market, but it was actually fentanyl, caused a lot of deaths. You want to, yeah, last summer. Yes. Sadly, a lot of people died. And you can take a look at this. When someone's desperate, they're not going to stop to notice the differences. When someone's buying something on the street, there's not a lot of quality control. And unfortunately, several of our Sacramento County residents died because they thought they were taking hydrocodone when it was really actually fentanyl from China. And the Xanax also, yeah. Desperate people do desperate things, and that happens locally. All right, so with the components of a substance use disorder or addiction, there's the physical component, there's the withdrawal. Withdrawal can be immediate, of course, lasting approximately 72 hours of the horrific, hell-like GI syndrome that people will often experience, hot and cold, all kinds of things. And alcoholism withdrawal can last generally up to 14, 16 days before they're medically able to be stabilized. Post-acute withdrawal syndrome is a condition that can last up to 18 months, where we know from the research that periods of time, it's like the brain reboots, and for that period of time, cravings can become more prevalent in the picture. Again, the need for comprehensive supportive care. Psychologically, again, our culture condones you can't have fun without a drink or using something. And some people, because they've done it a while or hang out with people who do it a lot, don't know the difference. Part of what we'll get into with recovery is a radical shift of how you do life. But to believe that one can function better, if you go back to the paradoxical response, if somebody feel more confident and energized taking an opioid and they've got 2 shifts to cover, they can believe, well, I can do better with a hit of that. And that can continue for a very long time or throughout their life without good care and accountability. Now, I want to just stop for a minute and I realize there's a lot of slides, so if I talk rapidly, I'm not manic. I just want to get through all these for you. Guilt and shame. Guilt says I've done something wrong or bad. Shame says I am something wrong or bad. And for many of us, we grew up with the message, somehow we're not as good as. Somehow we're defective or worthless. Not everybody grew up in a loving home. Now, what does that have to do with this? Well, there's a type of shame called toxic shame that sort of has its own little personality that goes with the person, but they will never admit it to somebody, that I feel not as good as, that I feel defective in some way. And so it shows up in the professional life. When somebody is operating from that space, some of these behaviors show up. Some people will wear their anger on their sleeve, and if you don't get close to me, you won't see the real me. And so those people are not fun to work with, but they happen to be around. These are all, by the way, these coping mechanisms, they are on the unconscious level. So just their way of protecting the heart. Control, manipulation, not that any pharmacists or nurses have problems with control freak, but that can be part of the picture. Distancing, perfectionism. I've had the pleasure of working with pharmacists and also at times with your team. And I noticed that perfection, because they're such high achievers, going for excellence, which is a good thing. However, there are times when excellence turns into perfectionism, which is really a slave driver. If it's not a 10, it might as well be 0. I always love a quote by a psychologist, Dr. James Dobson, says, a perfectionist is somebody who takes great pains to accomplish something and then gives those pains to others. So. Grandiosity, I'm the best of the best or the worst of the worst. All that black and white thinking, low self-esteem, but I'm going to do everything I can to cover it, because if you knew me, you wouldn't like me. Mocking, joking, denial, minimizing, big time. Over anything, it's interesting again, healthcare profession, what did we do? We overwork. And our job loves us for overworking. Anytime I hear, oh, that person is the pharmacist of the day, month, quarter, year, I'm thinking in my head, can we get a drug test? Because something's got to keep that person going. Anything that's overdoing generally is an unconscious way of protecting the heart. I don't have to deal with my stuff if I'm busy dealing with everybody else's stuff. Blaming, frozen feelings, these are all things that can show up in the workplace, but is actually coping mechanisms. Now there's a spectrum of addiction or substance use disorder. It's not how much one drinks or uses, it's not even the frequency, it is the relationship that is prominent. It will progress to more use because of the dopamine depletion in the brain. Once somebody uses a lot of that up, then the cravings will fit in at the brain level, and they'll have to use more just to get to level, and we'll get into that. This feeling chart is a good example of that. This is the general progression of somebody's use. Again, some brains are different than other brains. People start out, they're playing around, not unusual, whether it be in their teens or college years. And if you notice the priorities, that's a biggie. And look at level 1, going into routine use, hardy folks, that starts getting in, maybe gets a DUI. One would hope that's enough. Sometimes it is, sometimes it isn't. Some of the new friends may be those who use as well. And pretty soon, there's going to be some changes going on. As you can notice with the abuse going on, how that changes, level of pain changes, the loss of control. People start making rules for themselves. Well, I'm only going to drink on the weekends, or I'm only going to use when I'm really hurting or whatever. And so some of the values change, and they start breaking their own rules. Okay, and there's defenses that come up, start not feeling good about themselves. Who are you going to tell? Who are you going to tell? And you notice again, getting the substances starts getting much higher priorities. And then at the end of that, people use to feel normal. They're not using to feel high. They're using so that they don't go into active withdrawal. And pharmacists are not immune from that.
Where would you say, Stephanie, that most of the participants come into our program? At what stage?
I would say 4, but often 3. So a lot of them will come in with 3. Yeah, 3 or 4 when they get to the point where they're breaking their own rules. I have many individuals who have come to us and who said, I would go to work thinking I'm not going to divert medication. And then I end up doing that. And I bring it home and I use it at night. And that merry-go-round keeps going faster and faster, and I didn't know how to get off. And I knew I would die. I'm so glad I got caught. we're in the business of saving lives, protecting California, and saving good people's lives. So, okay, mental illness. If some think it always has to be a trauma in one's life, it doesn't. Again, sometimes that genetic connection, we know that there are certain mental illnesses that often have a family connection. Major depression, bipolar disorder, even some schizophrenia vulnerabilities. And so sometimes there is a life event, sometimes there's not. And sometimes it's a combination. They're the genetic, the biological, and the environmental. Heavy marijuana use, in California, we have to brace ourselves for the new law, but it can trigger psychosis. So can methamphetamines. So can cocaine. So can a lot of other drugs. So there's a lot of facets to mental illness, and many of our participants have mental illness and a substance use problem. For some, it's just like a self-medication for that mental illness that can sometimes show up. So that's something we just want to point out.
And to mention that it's not specifically the diagnosis. The Pharmacist Recovery Program manages not only substance use disorders, but also mental illness and dual diagnosis, which is, as Stephanie mentioned, a combination, co-occurring disorders. But it's not unusual at all for individuals with the symptom of a mental illness to self-medicate and try to manage their symptoms themselves. Some of that goes back to that invulnerability and that denial. It's probably more prevalent in healthcare professionals. And the other issue is it's not so much the diagnosis. It's not that we're looking for someone who's bipolar or with severe depression, but really what we work with in the program is the extent to which the mental illness affects their level of functioning in the workplace and in their ability to think rationally and abstract thinking and problem solving and all of those things that are required in a job.
Exactly. And so it's to the extent, does this affect one's practice? Again, no one asked for mental illness and it's treatable. No one asked for substance use disorder and it's treatable. So personally, I think that labels belong on cans and not on people. There's a lot of stigma with both of those. So it is not uncommon that people don't even connect the dots that they may be self-medicating a mental illness that may or may not be diagnosed. And as they continue in our program, they learn a lot about themselves and about their disease and how to manage it so it doesn't manage them. So, yeah, the program monitors compliance with the treatment. We get many, many reports from many areas very often. Pharmacists will be sent to a psychiatrist for medication management, to a therapist to work on any issues of mental illness, along with treatment for substance use disorders. So we, as case managers, we get reports from all of these different areas and compile them for this program. What is enabling? This can be a pretty complex issue. Trying to help somebody with a problem with either alcoholism or substance use, other substance use disorders or mental illness, doing for them what they need to be doing for themselves. And it's not intended to do harm, but it actually weakens the individuals. Very often spouses, family members, sometimes staff team members will do that. They'll kind of think, oh, they're just having a tough time, let me rush in and help, because you care about your team member. And this calling in sick, again, a lot of times that has to do with a family member making excuses for the poor performance. There's some actually managers who fall into that. Some managers will call, well, if I say something, I'm going to get him in trouble. It's like, would you rather read his obituary? Say something. Avoiding talking in case somebody gets upset. Again, if the anger is on the sleeve and keeps people away, they don't have to talk about it. They don't have to talk about it. And for many people, they have not learned what personal accountability looks like and how to be supported in doing that. bailing people out, loaning money, all kinds of things has to do with enabling. Some will drink with them. We have some people coming in, like I never had a problem, but the only way I could reach my wife was to drink with her. And pretty soon I got the problem kind of thing. And that often will happen, the de-stress sessions, those kind of things, or threatening to report and not following through. Again, when it comes to managers, sometimes we'll even see that. Finishing up, giving the medications, documenting. A lot of staff will do this, the no-talk rule. People don't, keep thinking why. We like to trust our team members. And everybody's human. We all have life stuff that occurs, so we help each other out. But sometimes this can get in the way and keep someone sicker longer and even kill them. So, general symptoms of, some of these are a little bit on the extreme side. Not everyone who's defensive has a substance use issue. And not everyone who avoids eye contact, and some cultures don't give you eye contact. Sometimes late to work has to do with maturity or how to figure out the life skill, getting in the car in time, those kind of things. But sometimes these all add up to a pattern, and that's why we just want to bring this up for in the workplace. When it comes to impaired judgment, that's a huge deal. When it comes to impulsivity in a clinical focus, that's a huge deal. The aggression, increased isolation, these things all add up. Obviously, muscle spasms, you'd have a concern about that. People join Weight Watchers, they decrease weight. Doesn't mean they have a substance problem. But anyone seizing on the floor, we're going to actually want somebody to take some drastic measures for that. Again, these are pretty extensive. The dilated pupils, pinpoint lethargy or jittery, these are just some general symptoms that are sometimes show up physically. So, these again, more history of back, neck, or orthopedics injuries. Sometimes folks will be on opioids way too long for those, and then it shows up in their practice. It is physically demanding. A pharmacist may not be lifting somebody, but by golly, it's physically demanding. If they're standing all day, if they're up and down, if they're on the phone all day, if they're filling things all day, you get injuries that they're prone to. And sometimes they are prone to more accidents using medication, which this example here, tripping, falling, car accidents, etc. Drug-seeking behaviors. A lot of trips to the emergency department. One of the things we do is we have an on-call case manager over the weekends as well. Anybody going to an emergency department has to check in with us by contract. And we know that people do doctor shopping. There's cures reports that help to know where has this person been, in California. And but sometimes we'll see that with desperate people doing desperate things, coming up with injuries too, because their brain is screaming for this medication. So we'll see that as well. Okay, how to recognize this? Again, discrepancies in narcotics. It's interesting that the pharmacists, when they're healthy, are really great in the hospitals because they audit every nurse's use, every physician's, medications pulled out, and we're able to see who is using or pulling out narcotics at a high frequency. But when the pharmacist is not healthy, that makes a big problem there. Discrepancy, orders, progress notes, drug records. A lot of times with pharmacists, their notes are changing, and that's where they'll, the discrepancies will be coming in. They'll recognize that pattern. Complaints from families, this is always a big one. We listen to what complaints are coming in from families. Higher PRN doses, again, these are some things that...
There are times, and we see in our practice that medications are substituted, and that can happen at anywhere in the supply chain, from the point where they're received in the pharmacy all the way through to the point where they make it to the patient. And those substitutions are what cause families or patients to say they're not getting relief from their pain, even though they're getting their dosages on time, or and it's not uncommon to see substituting saline for a powerful medication, the fentanyl or opiates or other things. So
yes,
that's part of that process.
Thank you. Because it starts with the pharmacy filling it. And so if the pharmacist isn't healthy, that can happen, or it can be a nurse substituting on the floor. There's a lot of, recall actually before I started working here at this job, I was working in El Dorado County, and someone had been diverting and filling morphine with normal saline. It caused a big ruckus, and with this whole team. So changes in the drug ordering, again, in the office at different times, pharmacists being at duty on different times, let me help, and odd behaviors. Again, patterns. We're looking at patterns. If somebody, leaves to go to the car and they're taking a nap, that may be something to just pay attention to. Longer and longer breaks, those kind of things. We're looking for patterns. Needing reminders to complete records. Again, with pharmacy, a lot of times it's the changing of the records, the comprehensive record taking suddenly changes, defensive, and the tampering.
And those of us that aren't prone to tampering with the medications, it's hard to imagine how that's possible. But there are many, many ways that medications can be tampered with. The vials can be opened or I lost my word. I'm sorry. Intrusion of the substances. And there's a story that's been repeated throughout from the state of California. Somewhere here in the Central Valley, there was a surgical technician that was diverting fentanyl from the operating room, and the way he was doing that was by cutting off the top of the ampule, marking it with a pen, breaking it off, extracting the fentanyl, substituting it with saline, and gluing it back on with that special super glue that's made for glass and crystal that doesn't show, and measuring up the little line so that it just goes right back in place. And the way that they finally figured it out, the staff, the nurses, the anesthesiologists, everyone involved were saying, this must be defective. There's something wrong. It doesn't pop when we open the ampule. It seems to, they didn't hear the vacuum. Eventually kind of looked into it and figured out what was happening with it, that it was being but even those solid ampules can be tampered, and
Desperate people doing desperate things. Fentanyl patches, people getting them out of the waste. We find people dead chewing on fentanyl patches. Prescription pads missing, or pages inside the prescription pads. The nice thing about the electronic is that there aren't so many prescription pads lying around anymore, but some people would take maybe page 8 in a stack of 40, people won't even notice it's gone. Disappearing patches, again, those are a big deal nowadays, and sometimes it's for a family member, sometimes it's for a boyfriend or a girlfriend or for somebody else. And that's what we listen. We listen when there's any chatter about any concerns. And most healthcare professionals don't self-refer. And they rationalize to keep going or making their own rules. But so much of it has to do with shame. Who am I going to tell? I'm a failure. I just keep blowing it. And I'm too embarrassed. In fact, most healthcare professionals, they could be dying in front of you and you wouldn't know it. Number one, we're way too considerate. As heart people, we're way too considerate to give you our problems. And secondly, we're way too filled with shame to even admit it. So I always consider when people come to us that they're emotionally hemorrhaging. There's so much shame, it just goes through the phone. And to offer hope to somebody is a big deal in my book, because they're worthy of that. So some of the steps to prevent diversion: reviewing the policies, particularly narcotic waste procedure, enforcing it. I've done staff meetings at 6 a.m. staff meetings at UC Davis, talking in PACU for the nurses who are just kind of leaving the narcs around, and it's not unusual, and that happens in pharmacies as well. When somebody needs something quickly, a patient going south, everybody moves, there's stuff all over. But reviewing the actual, I have to see the waste before I sign for it, is a big deal. Creating standards in ordering and prescribing, again, not leaving pads around is a big deal. And And just to take a look at that every facility, be encouraged to do so and to double check if something is outside of the normal range, that you really, somebody look at it immediately. Establishing education and training. This is, again, always needed. Most people don't know about our program till they have to. And this program's been going a long time. And one of the things we do is we go to facilities, even if it is at 6 in the morning, to speak with HR, with staff, with management, pharmacy schools. I love talking with students while they're still quite idealistic, and teaching them about self-care as well. Camera surveillance. This has been so helpful in high-risk areas. Obviously, you have to be a little discreet with the cameras if you put them in the bathroom, but a lot of people try to overdose in bathrooms. And so cameras around med rooms, big plus. And when something goes wrong, to have that ready to launch the investigation. At that time, this person's also so vulnerable to suicide. So it's important that confrontation occur with support. And reviewing to help avoid it in the first place. Pain management. Now, finally, in our country, we're hearing more about let's do something besides giving people boatloads of opioids for chronic pain management. There's other things to do. When it comes to substance use disorder, it is a long road. It's like everything has to change. Every point of reference. It's if somebody had a stroke and has to learn how to walk again and talk again and move their hands again and think again, every point of reference changes, but there's hope and there's help. Different triggers. Again, the brain has that memory bank in the hippocampus, and any memory also has an emotion, and so triggers can come up. And one of the things we help to teach and support is be ready for that. What do you do instead? And keeping people connected to a support team. We don't judge, we support. The intervention program, you can see this, where we're at today, over 3,000 successful completions. And if you think about 1 in 5 healthcare professionals, we have a lot more to do. There are a lot more people suffering alone. Some are dying alone. Some are pharmacists, and they're desperate, and they're scared, and they're dying. So our first job is to protect the public, as is yours. Our second job is to return pharmacists and interns pharmacists to safe practice, your students as well, through intervention and rehabilitation. You see the circle there? These are all a part of it. We work with all of them, and we see people who get not only a handle on the substance use disorder, they get their life back. There's Maximus, the worksite monitor. Jenny will go into a little bit more. Somebody who's on site with the pharmacist to offer that support and the monitoring part. The support group facilitators, most of them are licensed therapists or very seasoned California alcohol and drug counselors. And they meet with other professions as well to be a support and also a resource. And of course the PRC. Yeah, you can do that. Before I leave you, I just want to thank you for your time and for your investment in pharmacists in our state.
I'm going to go into a little more detail about what the PRC is and how it works, so that you can have kind of the broader picture of what we do. This is a high-level view, so please don't hesitate to ask if you have any questions as we go. The pharmacist there's admission criteria that's in the enabling statutes, and that is that they are licensed in California. They have to be diagnosed with a substance use disorder and/or mental illness. The program is considered to be a voluntary program. They have to request admission. In some cases, that means that request comes as part of a stipulated settlement, so that's the voluntary component. And although it's a very stringent and sometimes difficult program, it is a voluntary program. The pharmacist does not meet the admission criteria if they present too great of a risk to the public. In other words, they have a history of causing patient harm or death. There are several types of referrals. Some of these are unique to the pharmacy board. So there's board informal. That's a licensee who may have an investigation pending. They've come to the attention of the board, but the board inspector may recommend that they check out the diversion program. They may seek admission into the diversion program. The probation referrals are the ones that have already gone through the process and have agreed to participate in the program as part of their stipulated settlement, as part of their disciplinary action. In lieu of is someone who's under investigation and referred to the program to be assessed to determine whether or not they have a substance use disorder or a mental illness. And so we have a pretty extensive assessment process available to them. And a self-referral is someone who identifies that they have an issue and they come to us. The reality of it is that it doesn't matter if they're self-referred or they come to us knowing that there's an action pending on the part of the board. Participation in our program follows pretty much the same path for everyone. So it doesn't really give them any particular advantage to come in ahead of a complaint or a process. Maximus is the administrative vendor. So Maximus is a company that has programs all over the world, and we are a very, very tiny component of this much larger company. And so we have bid on and won the contract under the Department of Consumer Affairs, and as Stephanie mentioned earlier, with 8 of the healthcare licensing boards, pharmacy being one of them. And so we are responsible to have a toll-free number 24 hours, 7 days a week, holidays included. So we all rotate being on call. And so we're available for any type of sobriety emergency, medical emergencies, although we instruct them to seek medical attention. But if one of our participants is headed into the ER, we ask them to give us a call and tell us what the situation is, and we'll help them work through what medications might be appropriate or safer for them to use given their history. We conduct comprehensive assessments. Our case managers all do an intake assessment over the phone based on the addiction severity index, and then after we've done that and done that initial kind of high-level intake assessment, we send the new applicants for a face-to-face assessment with a licensed clinician in the community, usually a therapist or psychologist, and there are several throughout the state, so we try to match people up with someone in their geographic area. And then if it seems appropriate, in most cases it is, we'll send our pharmacists and pharmacy interns for a 3-day assessment that is specific to professional, healthcare professionals. And they do a very extensive battery of tests and also include the individual in the program that they're managing so that they get the benefit of being around other people with a similar diagnosis, and they are assessed throughout the day as part of that program. And some of that battery of tests, can include a lie detector test, it can include a personality inventory, a depression inventory, many different tests are available. And then we monitor and support our applicants and participants. So our case managers are not just record keepers and enforcers, but are also all clinicians and responsible to support our participants as they begin and progress through their recovery, whether it's substance use disorders or mental illness or both. And we provide effective case management. So our case management is really making sure that they're getting the treatment they need, getting the support from support groups, as I mentioned, assessment, and all of those things we're keeping track of and working with them through that process. I'm sorry, I already talked about the intake assessment by phone, and at this point, the pharmacist agrees to discontinue practice, and that is for a period of at least 30 days, usually longer than that. But they're removed from it's not a disciplinary process. They're not suspended, but they agree to discontinue their practice for that initial intake assessment period. Let's see, and I did all of those first 3 bullet points. The entry into treatment depends on what comes from those assessments and what level of treatment is needed. There are several levels available to the folks coming into the program, and it really depends on what their history has been. Have they diverted from the workplace? Have they used opiates? Have they used alcohol? Is it purely mental illness? And so all of that is taken into consideration in the determination of what level of treatment is appropriate, and typically done in consult with the individuals at the board that we work with.
Give a couple examples of that. Is this detox, or is this, and where is that done? And
Yes, and so an example. So we conduct an intake on the phone, and we determine that this individual is still actively using opiates and maybe is running out of a supply, or has made the determination that they want to stop using, or their prescription's up, and so that would be someone that we would refer into a detox program for safe weaning and detox from that substance. Alcohol, same kind of thing. So. There are several different treatment facilities that are available to us. Some of them specifically work with healthcare professionals, and others are more general public, and much of it depends on what the participant's history is of what their substance has been, and also whether they have insurance or not, what they can afford, whether there's a source of funding for them, whether the facility can work out a payment plan with them, which is often the case, scholarships.
now with Maximus, and you talk about self-referral. Now, do insurance companies cover you're essentially a case management company?
Correct.
That. Oh, I need a mic. Okay. Catch on any day now. You're essentially a case management company that directs access, because access is just terribly difficult for rehab. And so, does insurance, if a person were to self-refer, does insurance cover your services?
Not our services.
Oh, okay.
Because we're not a treatment provider.
Oh, I know
So-
that. And
So yes, where they're referred for treatment, or where they choose to go for treatment, insurance
that's-
typically covers, yes.
Okay, but so if someone was referred to Maximus, what would you charge? Would you charge the individual for the direction, or I'm not real clear on this.
To the cost to the participant specific to the administration of the program, there is a monthly fee, and the board subsidizes that. So the participant pays a copay. It's $100, I think, or something.
Yes.
And then the balance of it, the board already pays. But if the person can't even afford the $100, then they can submit an appeal, and we will cover the entire cost of the program administration for them.
Okay.
385, right in that range. Actually, I do have one of the very last slides I have breaks down all of the
okay.
fees.
Great.
So we
Another
talked about all
question
the
before you
costs.
go on. We see many more cases of drug diversion by pharmacy techs than by pharmacists. This program does not cover pharmacy techs. What do they do?
So through the terms and conditions of their probation, we monitor them from the staff perspective. So many of the terms and conditions within the disciplinary guidelines mirror what is in the program requirements for Maximus, the worksite monitor, the prescription monitoring, all of those. And so they're monitored by the probation team that is comprised of pharmacists and then staff as well.
If I can also refer to your question,
there are many times when I can get a written consent from one of our new people to speak with their insurance because they work in a safety-sensitive area, just like the airline pilots. And so often we can advocate with the insurance people on their behalf to say, look, this person is in dire need of your services that he or she pays for, and and to be able to help to facilitate them to get into the access of what they need for treatment. You are correct that treatment can be a difficult commodity these days, but from our end as a case manager, once I get that written consent, I can advocate even with insurance on behalf of the client.
No, it seems like a valuable service, so.
It's an honor to walk alongside people and watch them get their life back.
So and there are different levels of treatment. So it might be detox, which would be the most intensive level of treatment. There's inpatient or residential treatment, which goes on for a longer period of time, anywhere from a few days to 90 days, or maybe even longer than that, depending on the individual. Intensive outpatient programs, which they live at home, they go in during the day and attend, and that can be anywhere from 3 hours a day, several days a week, to every day for 5 or 6 hours during the day. So all of that is available and kind of depends on their history and what's appropriate.
After their initial treatment, we generally ask for weekly or continuing care for at least 12 months, an aftercare component, a relapse prevention plan, little group that takes place at their treatment center. Again, we want comprehensive. The longer, the better. Our studies show in offering success. So even after the initial treatment, there's the ongoing continuing care.
When they come into our program, they're very, very busy initially because we really fill up their days, not only with treatment, and I think the next slide will tell you the rest of it, but we have, and that's part of the reason that they're removed from work, and we talk to them about the safety and about them taking the time to take care of themselves and address these issues. Oh, and so the last bullet point is that they're required to contact the case manager once a week when they initially come in the program. It slows down to monthly after that, and it's a phone call. But initially it's weekly because we're walking them through this process, and most of it's usually pretty new for them. So we require them to attend 12-step meetings. If it's a substance use disorder, they're attending 12-step meetings such as AA or NA or Pills Anonymous or what else is there? I don't know. And then if it's cocaine, right. Yeah. And if it's not substance use disorder, it's a dual diagnosis, we may have them also attend Codependence Anonymous or Emotions Anonymous. And we customize that recommendation to what their individual needs might be. But initially, when they come in the program, we require them to attend meetings daily, a minimum of 90 meetings in 90 days. And it's that immersion in the process. So that's in addition to, if they're in an intensive outpatient program, in addition to that program. In addition to that, we have them attend a health support group with other healthcare professionals run by a licensed clinician. And typically when they come in the program, that's twice a week as well. And they still have to go to that daily meeting at the 12-step meeting, and they still have to go into treatment if that's a treatment day for them. So they're pretty busy when they first come into the program, and it really is an immersion in the recovery process. So I'm going to shift gears a little bit and talk about the drug testing. We use random drug testing through a third-party administrator that's a lab provider. We require a daily check-in with the provider. There are multiple ways that they can check in, by phone, by mobile app, or by web, so they have different options. But once they check in, and there's a limited window of time that they can check in each day, once they check in, if they're selected to test, which is a random test selection, they must test on that same day. That's to avoid any tampering or substitution or flushing of their system that might occur if they had a longer period of time to prepare for the test. So the testing is a pretty rigid process. The California Test Panel is one of the most comprehensive panels in the country, if not the most comprehensive panel. Jenny's smiling, because that came from our pharmacy board many years ago. And when they first started working with the diversion program, that panel was created back then. It's evolved over time based on what's available substance-wise in the community, but it's still a pretty comprehensive panel.
Is the test always urine? I know there's urine and hair. So
And
when they
and
call
blood.
up on blood, so when they call up, or is that part of their protocol that you would say, Debbie, you get urine, Ellen, your blood?
Everybody okay, so there are different types of tests. There are the urine tests, which are the most common, the kind of the standard random urine drug test. But we also have a PETH, phosphoethyl alcohol, which is a metabolite of alcohol that is a blood test and can detect urine in for about a 3-week window. We have ETG, that's part of the urine drug test, that detects alcohol for about a 3 to 4 day window. And then we have hair tests, which can detect substances for up to about 90 days, sometimes more. And so those are, everyone coming into the program has a PEth test and a hair test, and usually we know that they've been using substances. We expect those to be positive, especially the hair test, but we want to confirm that what they're telling us is what they're actually taking. So we do the baseline hair test. And before they leave the program, they do a hair test and a PEth test to ensure that the urine tests have been picking up any other substances. But it's a random process otherwise.
And how much would that cost them, just roughly?
The urine drug test is $62.50 for the test plus the cost of collection. So we use just an average of about $100 a test. The cost of collection can vary depending on where they're going, what day of the week, and if it's a holiday, because it has to be a same gender collector.
These are observed tests by the Department of Transportation, so there has to be, even on the weekend, a male or a female observer.
All tests are observed. And then they're reviewed by the Pharmacist Review Committee the next time that the committee meets after they come into the program. And all of the assessment information that's been collected, the drug tests up to that point, and then the committee reviews the plan going forward. I'm sorry, so I already went into this. So the frequency is typically 52 to 104 times a year during that first year, and can reduce to 36 times a year after that. It's random. Our cutoff levels are very, very low as well. I mentioned that the test panel is comprehensive and also very low cutoff, so we're detecting at lower levels than many of the other programs do. So the Pharmacist Review Committee formally reviews and accepts applicants into the program, formulates and approves the ongoing recovery plan that is initiated by the case manager and then enhanced or reviewed and approved. And any changes, if the participant down the road is requesting a change to return to work, to reduce their meeting frequency, to make any other change along those lines, they must have to request it, and it's brought to the committee for review. And then the committee really looks at the entire case history and how compliant are they, and have the drug tests been negative, and are they able to, very often we'll assign essays for certain parts of the process, and are they able to give us a truly thought out, introspective reflection of where they are in their process.
Who makes up this Pharmacist Review Committee?
It's established in the contract, and it's the clinical team from Maximus, and then it's our supervising inspector over the team who's a pharmacist, and then we have a specially trained staff manager in the area as well, and that's actually Debbie Mitchell, and Joan Coyne is the supervising inspector.
Okay, by specially trained, how?
In coursework in substance abuse, but
Oh.
really part of the thing that we at the staff level are doing is we've got the clinical piece covered by the licensed clinicians, and we're there to represent the public and our mandate. And so you're balancing the two.
Okay, thanks.
I have a question. On the, I'm thinking 100 tests at $100, you're talking about $10,000. So I mean, I'm thinking about our techs and our pharmacists paying this and they're not working, so, how, I mean, are you guys just billing them and they're gonna pay eventually? How does that work?
So I'm going to take that one if that's okay, Cheryl, because aside or alongside of the pharmacist recovery program are the terms and conditions of probation. But if you remember, several years ago, there was Senate Bill 1441, and 1441 was designed to develop uniform standards for healthcare practitioners with substance use or abuse. And as part of those uniform standards, they established as part of those standards, the testing frequencies. And so we do rely on the testing frequencies established in the uniform standards along with the clinical picture to establish them. In the case of an individual that's not working, the drug testing frequency can be reduced per those standards to 24, and we do have people that are testing at a much less frequent rate because they are not working, and so the risk to the public is not the same.
But I guess to Cheryl's main point is the cost. So what if we have someone who says, you know, who's like doing 100 a year, but says, I can't afford it, but, you know, we're not interested in decreasing the quantity?
Yeah, so although the uniform standard says 52 to 104 times a year, I have never seen anybody test at higher than 52. There may be occasions where, because of a drug screen result that shows as an out of range or a dilute or something, you may be adding another test in just to make sure. But when the policy was made with respect to the uniform standards and establishing those testing frequencies, there was significant public comment and concern about the drug testing frequency, but the underlying policy was that the cost for the test should not be the factor in determining what is necessary to ensure consumer protection.
So if someone couldn't afford it, then they would be non-compliant in the program, and then they would they could potentially fall out of probation.
So they could. I can't think of a single participant that we've had in the pharmacist recovery program that has been kicked out because they could not pay for their testing. There's other costs that are associated, and so one of the approaches that we do try to take is to try to see if there are ways that we can achieve cost savings in other areas. So perhaps it's the board paying for the entire cost, so that relieves the administrative fee that is about the same as the testing for the month. So there's other things that you can do to look at it. You can look for perhaps individual therapy that's offered through a clinic or a county program so that they're reducing their costs in other areas. But like I said, the public policy with respect to the testing was very clear at the time the standards were developed.
But that applies to pharmacists. What about the techs? Because they're doing the pharmacists and interns, so what about the technicians?
So with the technicians, the drug testing is the same because of the standards are the same, but you look at the criteria established within the uniform standard to try to manage it. If a technician's not working, generally we are going to reduce it down to the minimum testing. Not always, because there's a big picture to look at, but there is some flexibility within the standards themselves, and we do try to evaluate it on a case-by-case basis.
So instead of Maximus setting up the testing with a testing entity, it's our staff that's doing it?
Yes, consistent with the guidelines.
I have a question. I'm assuming that it's okay to ask questions now.
Yes.
But with Stephanie, we were holding our questions.
Oh, sure.
Okay.
Certainly.
So with regards to what everybody's talking about, the economic impact on a individual or a family when they're in Maximus, no way do I want to minimize the importance of rehabilitation or the issues that these people probably have. But sometimes, as we sit here and look to our colleagues that are either in a program or in need of a program, we hear stories of just devastation of the family during this whole process, and the financial devastation to these people, and not just the cost of the testing and all the associated fees with the Maximus program, but the restrictions that they have in the workplace in trying to find employment, given the restrictions limit the employment, if there's any employment at all, and then they're faced with these costs which are sometimes impossible, and they fall out of the program for a financial reason. It just seems that there's a spiral. I mean, they're already spiraling, as you said. They're on their way down when they finally enter the program, and that I can see where you're trying to rehabilitate them, emotionally and physically, but the spiral continues, almost becomes a death spiral with regards to their lives, their families, and their profession. And as we sit behind here, or as we look at the different members of our profession that we want to see helped, sometimes, I have reservation about them being required to adhere to all of these issues, because it seems as though that's the final nail. And I mean, how do I deal with that as somebody who's trying to be fair and trying to protect the consumers and even protect these people? So what do I do about that?
Well, the participants coming into the program, if they're diagnosed with mental illness or substance use disorder or both, are typically eligible for disability. So there is some income coming in when they're out of work, in most cases. And that's individual, depends on how long they've been working in California and all of that. But in most cases, they're eligible for disability, and that helps. They can work, if they're able to work, they can work in a non-medical setting to help bring in money if they need to. I mean, that initial couple of months is pretty intensive for activity, but once they get through that first 2 to 3 months of entering in the program and the assessment, as I mentioned, and how we really keep them busy, and then that begins to slow down and they kind of start returning to their lives. If they're not ready to return to work in a healthcare profession, then they can choose to work in another place.
That's much easier said
Sure.
than done.
Sure.
And so, I mean, I hear you say it, but you ought to hear what they've got to say about it.
Sure. Oh, I do.
If I could
I know.
add to that, sir, I get it, and we get it at Maximus too, because we hear it. And as a case manager, that's where that support comes in as well. We look to work through in their community, what can they do? We help people to get disability. We work with the health support group, people at real close range with this particular person, if it is the financial piece. Until the law changes the frequency, we're BOP is bound to that, but I like, how Ann is saying they try to cut down on other things. We recognize that there's often a lot of financial wreckage when somebody comes in, and that's why our first goal is to stabilize. And yes, it's aggressive treatment, but this kills good people. Initially with all the meetings and the groundwork to be done so they can stabilize, and from there to learn also how to receive help. I do a lot of close range working with my participants about financial issues, where there are resources. We have a lot go on food stamps. We have a lot with TANF. We have a lot at this point, and it's difficult for a professional to even accept that. But we say you've paid into the system. It's there for right now, for today. And when you get back on your feet and back to work, you can always give back. You can always help volunteer somewhere to help out. Food, church food banks, things like that. We're familiar with what's in the communities. It's not easy, but I do know that they don't have to do it alone. And I hear your heart, and I'm glad that you are concerned to bring up the issue, because financially it is difficult. But as much as that we can do, we work within. I know the case manager for the pharmacy board is in constant contact with Debbie about what is needed for this particular pharmacist or intern in order to enhance success in the program.
So out of all of the pharmacists we refer to you, let's say we look at the last couple years, how many of them, what's the percentage of them that actually come back and are can get their licenses back and are rehabilitated?
I'm not sure how to answer your question. I'm kind of sorting through what.
So
what is-
let's say you send you 100 pharmacists to go through this program. Some of them are going to go ahead and participate and be active and come
Yes.
back and get. How many of them actually fall through and don't?
Don't stay.
What's our success rate is what I'm asking.
Purely successful completion program overall. I don't have the pharmacy number specifically, so overall in the program, successful completion, which is not moving out of state, withdrawing from the program, any other reason, is about 60%.
At 60, okay. And then the other question I had real quick was when you were presenting the information about the DUIs, one of the things our board has really wrestled with is when we do have licensees that have DUIs, and they not necessarily DUIs related to work.
Right.
Or is that something that you believe is indicative of greater issues, or is this something we really need to be looking at, or should we, and I just wanted to get your thoughts on that.
It takes a lot of work to get a DUI in California these days. We don't have that many CHPs on the road. Not everyone who gets one DUI has a full spectrum issue going, but many do. The idea that the license is good for more than 8 hours comes into play here as a professional. And if the license was only good for 8 hours a day, California would, quote, be safer, one would think. But it isn't. And because of that, it is a violation of the professional code when a criminal act is occurring. And so I say pay attention to them. That's where the clinical assessment comes in as well. Is this person actually have a full substance use disorder? Is it more of a, follow up for a while? Those kind of things. We don't know on face value. We have to do clinical assessment deeper to find out how long has this person been doing. Was it a dumb decision? I mean, there are some dumb decisions made by healthcare professionals. But the fact that they weren't working does not mean that they don't have a problem.
Thank you. Any other questions?
I
Board
just,
members?
oh, sorry.
Yeah. On the same line of thinking, yeah, I keep having problem with understanding. From your experience, most of the people on DUI, you interview them, you talk to them, so I just want some feedback, the feeling you got. How many of them, what's the percentage, the DUI candidate affect their work? Have problem at work?
Again, sir, it's case by case. It depends on how much
feeling,
drinking
yeah.
they do. If it continues to progress, it will eventually affect their work. Does it do it today? Again, some people will go to a wedding, they'll drink too much, and they'll think there's no designated driver. Maybe I'll be the one to drive home, and they get a DUI on the way home. I would have to have a clear diagnosis. I'd have to have a clearer assessment than just the face value of the DUI, knowing the circumstances, also knowing their history. When did they start drinking? How often do they drink? Not that everyone tells us 100% accuracy on the intake, but we get a sense of what's going on. The frequency, things like that. I don't have a statistic. I know that it's harder to get a DUI these days. Generally, it's a thought that it takes about 200 times of somewhat impaired drinking to get a DUI. That was the last statistic I heard. But I also know that...
What did you say? How many times?
About 200 times. But that is a statistic but there's also dumb decisions that have to figure in too. And again, because healthcare professionals, we don't connect the dots too well, applying anything to us. That CAPE thing comes out, I'll be the rescuer, I'll drive us all home, and often there's impaired thinking with that.
No, my main question is that, after you interview them, talk to them, you got a feeling, is it a lot of those the DUI cases, those patients, does that affect the work?
It can.
I know, but did they talk to you that they go to work drunk or interfere their duty? They did talk.
With one DUI, I don't necessarily see the drinking at work or going to work impaired, I mean, they could, but because it's a disease of hiding, so we just don't know initially. But there are some who do. Definitely with 2 DUIs, someone's got a problem, because again, it's a lot harder to get these days. But again, it depending on the circumstances around that DUI, what happened, who else was around. And when did they go to work? Do they drink? A lot of times people with alcoholism, they don't drink at work, they drink after work to deal with the stress involved, because the stress has to go somewhere. We're taught to take it in. We stuff it. But at some point, it's got to go somewhere. So a lot of pharmacists will drink after shift to, quote, relax. And a lot of nurses and a lot of docs, they'll do the same thing, because it's got to go somewhere until we teach someone about healthy self-care and accountable self-care and boundaries, when to shut it off, when to ask for help, how to not bring it home. Most people don't know that.
So
If they're getting, I'm sorry, did I interrupt somebody? If they're getting a DUI,
Yes.
like they're coming home,
Yeah.
and they're over drinking. Let's say they're not even getting a DUI, but they're coming home, they're sitting down, they're
Right.
drinking heavily, and they have to work now like in 12 hours.
That
I mean,
would,
what's the clearance rate? I mean, even if they came home and slammed it down like within an hour, and they have 12 hours to clear, couldn't it?
She's calculating out the half-life.
I mean, couldn't they?
well, don't the airlines use 8 hours bottle to throttle?
Yeah, they do.
I think what she's
I thought
saying
it was
though is
8.
it's more about the hiding behavior and about you not wanting people to know, and
I
it's
guess my
indicative of
point
a
is that
bigger
even
thing.
That it could, even though you
Within
think
24
you're only
hours.
doing it off hours.
Yes.
It could impact
it could.
you because
It absolutely could. Especially if it's less than 24 hours. You bet it could.
if it's less than 24 hours, then you could have
Absolutely. Speaking to yours
impact.
as well. Yeah, it could. Again, with the 1 DUI, we'd have to do a lot of evaluation around that. And when was their next shift? That's one thing I always like to ask. Well, were you in jail that night, overnight? A lot of times they are. But at least we know they're not working at that point. But yeah, it does make a difference.
I want to be cognizant of our time. And do we have more slides that we have left to go, or are we done with the slides? Okay.
Yeah.
I got one more question, Amy.
Before, while we're waiting for Jenny to come back, I'd like to just add one thing that we at the staff level do that wasn't mentioned in the list that Stephanie just provided. One of the things that affects us, even if it is 1 DUI, the higher the blood concentration of alcohol at the time they were pulled over, the more likely they're going to get more structured discipline as a result. So if I get pulled over with a .08, it's going to be different than if I get pulled over with a .28.
Right. Exactly.
And that is a real integral, and you'll see that in the type of penalty in front of you. As that alcohol level increases, especially as the time within which the time that they got arrested to the time they actually did the blood alcohol, which is frequently hours,
Right.
it also affects how we adjudicate the case, because I'm going to be comatose at .28. I'm not going to be up and walking. I'm going to be passed out. Somebody that can drive under that condition, and we've had people driving cars at .43.
Right.
That shows the tolerance.
Well,
Tolerance,
I got one more comment. I just since you guys in the field taking care of this kind of patient, I just want you to aware that it's very easy to be a DUI, because I have a margarita yesterday and I felt it, okay, and I have to spin around, walk around a little bit more before I start driving. So what I'm saying is a single drink or maybe a beer, but yesterday I got margarita and I really felt it. It's just single drink, okay? So what I'm saying is that very easily to get a DUI.
I was just saying, as far as being caught on the road with the CHP, we have fewer officers on the road to find DUI situations.
Yeah.
So Virginia, are you done with your slides, or you need to
Almost.
move? Okay, why don't we let you
I know.
finish? Okay.
We're running out of
I
time.
want to add one more thing first. One more thing. So, if a person, in your opinion, if a person has 3 DUI and been sentenced to jail, so should you still recommend us to send to you? And what is the chances of that person's still salvageable?
I would say everyone has a chance to be salvageable, sir. As long as they can breathe, they have hope, and they have the opportunity to learn a different way and get their life back.
They still could have a chance.
Again, a structured program with long-term accountability and support being a big factor there. No one gets well with an iron fist.
Okay, let's go move forward.
In the beginning of your presentation, you spoke about how addiction has been changed to disorder. And is that terminology alone, are we, not you, minimizing, the reality of it? It's, when I hear about AA meetings, and so they say, hi, my name is Stan Weiser, and I'm an alcoholic. And I think that that's important for the individual to, fess up, if you will, and to recognize what this individual, what I am. And I think that addiction is the same thing. I mean, here I am, a pharmacist. If you were my therapist sitting across the table from me and said to me, you are addicted, I mean, that's a very strong word.
It is, sir. Yes.
For a nurse practitioner or a physician, a pharmacist, or all other 5 groups that you. But yet we're calling it now a disorder, which I wonder if that word really softens, what I think I am and what my colleagues think I am.
Well, now it becomes not my fault.
What?
Now it becomes maybe not my
Well,
fault.
and again, the American Psychological Association decided to change the terminology. And they do that from time to time, just when everyone's used to one term, they'll change it. But these are the folks who do the psychology. And so I hear what you're saying. They changed it because of the stigma, because it is a spectrum disorder. It's a spectrum disease. I wish personally that they would have used the word disease myself, but it didn't come from the American Medical Association. It came from the APA. But people in our program, we have a way of breaking through denial in order to save their life, and so do the treatment providers that we send them to.
It's a chronic relapsing disease in much the same way that diabetes or cardiac disease, and the relapse rates are very similar.
Yeah, or cancer. Same clinical pathway as cancer and asthma. Yeah.
I can appreciate it being referred to as a disease.
It is a disease, yes.
All right, can we finish the slides?
I wanted to talk for a minute about returning to work, because this is an important component of what we do in the program, and that's, remember, our primary function is to protect public safety. So participants, they must apply to return to work. It's not a given. And there's no set time. That's not that once they hit some milestone, they're approved to work. And it really depends on their history prior to coming into the program, what brought them in, what was their drug of choice. It's a very complex disease as well, and so it's hard to answer these kinds of questions with just a single yes or no or a single number of an answer, because there are so many factors involved in looking at where someone is at any point in time. So we look at all of those factors, and how compliant are they now, and how are their drug test results, and what is their support group facilitator who sees them twice a week? What is their recommendation to whether or not they're ready to return to work? And where are they requesting to return to work? So what's the level of stress in that job? What are the hours? What's the structure of the pharmacy like? Once they're approved by the committee, and they must be approved by the Pharmacist Review Committee. So once they're approved by the committee to return to practice, and they're usually approved with a very high level of monitoring, we gradually reduce the restrictions over time. So let me comment on the worksite monitor. As I said, there's a very high level of monitoring involved. The worksite monitor must be approved by the program, and there's a set list of criteria that they have to meet to be approved. No conflict of interest.
So I know we're trying to hurry, but what does that mean, a worksite monitor?
So that's an individual in the workplace who agrees in writing to provide a monitoring over our participant when they return to work. And that level of monitoring varies, but it's usually very high initially. Daily, certain number of hours a day, direct supervision of their work.
Generally a manager or somebody.
It has to be someone higher on the organizational chart, so it can't be a peer, or if it's a pharmacist, it can't be a pharmacy tech. It needs to be someone at a higher level on the organizational chart with a pharmacist license, so that they understand the nature of the work and all the ins and outs of it. And then once that person is identified and approved, the case manager provides some education to the worksite monitor and discusses how to contact us if they identify any behaviors or any signs of a relapse in the workplace. We talk about attendance, tardiness, any incidents or any, any issues that they have with the actual performance of the job.
We also look up the worksite monitor's license online, make sure everything is clean there. Yeah.
Yeah. And if they are in recovery, we ask them to have at least 5 years of recovery themselves. So they're not coming in. Someone else in the program can't be a worksite monitor for one of our participants returning to work. And then once that documentation is complete and they're thoroughly vetted, they can return to work. We also look at the job description. And I mentioned all of that documentation. We have to have contact for the worksite monitor and the employer. So if there's ever an issue, we want to be able to contact both. So we have a release of information for the employer. And then, as I mentioned, we provide the training. We look at the org chart. We look at the job description. The worksite monitor submits an affidavit to us that they meet all of the criteria and they agree to the terms and they agree to the responsibilities of the position. And then the last stage in our program is a year of transition. So that's a minimum of 2 years of good compliance and negative drug tests where they can then request to enter the transition phase. The transition phase is that last year in the program with a reduced level of monitoring. But we have some extensive requirements to get into that level of transition, which includes a retrospective review of their life, their history, their substance use, or their mental illness, and what it has done throughout their lives and where they are today, what changes have come. We look for letters from families, sponsors, people involved in their lives. And
once again, that starts after year 2, so this is actually year 3.
Yes, ma'am. Yeah, after the beginning,
Minimum.
at minimum.
Right.
Exactly.
Right.
Not guaranteed at that 2-year point, but
And they do a personalized relapse prevention plan that's a living document where they are aware of their subtle and the overt triggers and what they do about it now. It's very comprehensive.
so the worksite monitoring level is gradually decreased, so it might go from daily to several days a week, or it backs off gradually as their performance supports that. They're not required to document meeting attendance any longer, and they are still required to test and check in daily for testing and to contact the case manager monthly and submit their reports. And then in order to complete, they have to demonstrate a manner of living that supports their ongoing recovery, honesty, abstinence from mind-altering substances, or compliance with a program, if it's a mental illness, a compliance with their treatment program. And they have to have at least that last year as well of clean drug tests. No other evidence of relapse. Let's see, I've said all of that. And I mentioned earlier, we do an exit hair test and PEth test to make sure that we've looked at everything. So we talked about the program costs earlier, and I mentioned I had a slide at the end. The intake assessment and the clinical assessment are no charge to the participant. If they go for a 3-day assessment, that the participant does pay for that fee. We also will provide an annual reassessment at no charge to the participant. That's something that will pay the fee. If they go into any treatment, the treatment costs are the responsibility of the participant. That varies depending on what level of treatment and where they go. And, as we talked about, it's hard to get into, but county facilities don't have a charge. So it just kind of depends on where they're going and what level of treatment they need. That $100 a month administrative fee that might be waived, or they can work out a payment plan with Maximus to pay it over time. The health support group cost varies from $50 to $100 a week, depends on where they're going, the level of licensure of the support group facilitator, and what they agree with the participant for the charge. Any health care is the responsibility of the participant, any counseling. The random drug test, as I mentioned, is $62.50 at a rate of 36 or even 24 times a year, up to a maximum 104. And that's it. That's our contact information.
Do you have an average cost? Do you have an average cost or a guesstimate of what your program, aside from the employee loss of income side, what does your what does your program cost? Is there an average rule of thumb cost? $20,000, $2,000? I mean, it seems that so often programs such as yours have a price tag. This is how much it's going to be a week, a month, a year. And so do you have something similar to that?
I don't have that number at hand. I will tell you that it varies by board. So the pharmacy board is a set number that differs from the other boards, and so that I don't know. But I do know that when we were audited at the end of last year, that was one of the studies that the auditors did, and they created a table that reviewed each board and the costs. And there's a little bit of a variance depending on a number of different factors, but they created that table with the cost by year and then the total cost, because over time the costs decrease.
Stan, we'll pull some data for you and we'll send it out.
Okay, cool. That'd be a big
It's
help.
available, I just don't have it in my head.
Pharmacists that are on Suboxone, and they're going to be on this for a while, eligible for being placed back into the workplace to be working with Suboxone therapy?
At this point, the Board of Pharmacy does not acknowledge, nor do any of the healthcare professional boards, the Suboxone. Generally, if somebody comes from a treatment and is on Suboxone, we ask for a scheduled taper from their physician. And at the point, if somebody is prescribed Suboxone, what we ask for is a scheduled taper from their physician regarding getting them off of the Suboxone. And when they get the first negative completely off Suboxone, it is used as this program's sobriety date for them.
So, do you think that being on Suboxone changes mentation, or that it affects it? Do you?
There's an ongoing debate about that, that it can affect the critical thinking centers of the brain. If somebody takes too much Suboxone.
Oh, I'm talking about someone that is truly making an effort of getting off of Suboxone.
Yeah, I mean, if, for
in a tapering situation. Can
Right.
they work in a tapering situation?
No, they can't work as a pharmacist during that time. Once they're completely off of it and we get 2 negatives, that then the case manager would speak to your program person about when to go back to work. At this point, working as a professional pharmacist on Suboxone is not approved by the Board of Pharmacy or any of the California licensing boards that I'm aware of, certainly not the 8 that we serve. And so, but if somebody is on a scheduled taper from their physician, that they can still be in the program, but they can't work as a pharmacist until we're getting negative results. A lot of times when people get off of the Suboxone, they will be placed immediately on the naltrexone, which is a complete opioid antagonist.
Right.
The Suboxone is only a partial antagonist, and the naloxone in it means if you shoot it, you don't get high.
Right. So I did not realize that there was a transition to naloxone.
At this point,
That's
that's what's going
typical-
on, right?
typical
Now,
therapy?
naltrexone, people can get Vivitrol, which is the monthly shot. A lot of healthcare professionals, I have the veterinary board, all of my veterinarians are on Vivitrol. And that works out really well. They go once a month, they get their injection, they're fine, and, and that stays with them. So that's often when they get off of one, they'll be placed on the other, and it really helps with cravings for alcohol as well. So.
Right.
So if a patient starts with a diagnosis that requires, let's say, a benzothiazide,
Okay.
and so they come in to your program with maybe multiple drug issues,
Right.
And alcohol, but they started with a valid benzothiazide prescription. At the end of the day, they can't go back to work until they're off of everything, including the benzothiazide that their physician prescribed for them?
At this point, generally, again, we talk with the attending physicians, often psychiatrists, and there are other approved medications that may be used instead. And even like, let me use an example of ADHD, Strattera is the amphetamine prep that many people do well with. When it comes to a benzo, sometimes Boost Bar can be used for anxiety. That is an approved medication. Some psychiatry off-label Neurontin, gabapentin being used for anxiety, propranolol, Seroquel. So those are approved medications. We try to work with the attending on behalf of our patient to be able to get what they need and still be able to be approved to go back to work.
So our goal is to stay away from mind-altering substances, anything that would change the mentation.
Any other questions? Thank you very much.
This has been enlightening.
Really enlightening.
Thank
Thank you
you.
for your time. Thank you for
Thanks for
caring
having us.
enough.
This is very,
about your
very
pharmacy.
informative. Are there any public comments or questions before we conclude? Yes, can you come up? If you can come up, please, because we're webcasting.
I'd like to commend the program. We actually have three employees that have been through the program. Unfortunately, one of them failed, but it's saved a couple of really good people.
Oh, thank you.
Thank you very much. Move on to the Ledge Reg Committee. Greg. Or you want to let's take a 5-minute break? Okay, 5 minutes.
Okay, here we go with the Ledge Reg report. First group is board-sponsored legislation, and basically all of these are moving, and these are bills SB 800, SB 351, SB 443, SB 510, SB 752. They've been covered extensively in the past, so the question I have is, does anybody have any questions about them? How about the public? Nope? Okay. We're moving. Next, legislation impacting the practice of pharmacy or the board's jurisdiction with recommended or current positions. Following measures were previously discussed either by the board or committee, and where the board either has an established position or the committee is making a recommendation. Unless otherwise noted in your meeting materials, a copy of the proposal and a bill analysis is provided in attachment 2. First one is AB 12. This is Administrative Regulation Review. The bill would require each state agency on or before January 2020 to review regulations, identify any regulations that are duplicative, overlapping, inconsistent, or out of date, and revise those identified regulations as provided and report to legislature and governor as specified. As part of our discussion, the committee noted the fiscal impact the measure would have to the board, totaling $478,000 for fiscal year end 2018-19 and $454,000 for fiscal year 2019-20. Our committee recommendation is to take an opposed position unless amended, offering amendments that either expand the time and or synchronize efforts with Sunset Review. It's currently in the Assembly Appropriations Committee suspense file. Are there any board comments? Are there any public comments? Moving along. AB.
We need to take a position.
Yeah,
Yeah, okay.
the committee
Then
recommended
do I
a
hear
position.
some kind of a, yeah, thank you.
Alacrity?
Getting straight here. All I need is a vote. It's a committee recommendation.
Got it.
This is AB 12, and our committee recommendation is take an oppose unless amended, mainly because of the high fiscal cost. And, the staff resources required.
So are there any,
All those,
we don't need a second, but we should get public comment?
I asked and they didn't.
Okay, let's take a vote.
Take a vote.
All in favor?
Thank you. Okay. Yeah.
Yes.
The committee
In favor of the committee's recommendation. AB 40, Cures Database. The bill would require the Department of Justice to make access to the Cures Database available to the practitioner through either an online internet web portal or an authorized health information technology system. As part of our discussion, the committee noted the board's long history of supporting the use of Cures. Our committee is recommending a support position. It's been referred to the Assembly Appropriations Committee. Do I have any board comments? Do I have any public comments? In that case, we're going to vote.
It simplifies the access in particular systems to review the data.
Okay. So all those in favor of a support position?
Oh, yes, sorry.
Cheryl, did you vote?
Trying to find it.
Okay.
So
Okay.
I do have a
Unanimous.
CARES question,
Yes.
and it's a reg question as well. And it's
Okay.
something that we discussed a little bit yesterday. And the issue is cures and cures-like programs that cross the borders of the state of California and other agencies that share information across their borders, yet we are isolated as far as our data and information is concerned. It's a self-imposed isolation. And so the board, I can't say the board, but there are some of us on the board that feels that the expansion of the data in both ways would be advantageous to practitioners and to the board here in California. So my question is there anything that we as a consumer protection agency should do legislatively in regards to that issue? And if so, how and when?
Jenny, do we have that ability?
I think perhaps I ought to respond to this one. We are working with the Department of Justice, which is very concerned that going across state lines using the system that the other states are using would compromise the cures data in California. I don't believe that that is probably the case. I think there's ways to prevent that, and we are working with the Department of Justice. The medical board is now working directly with us because they also want to go across state lines. So you've got the two key players in the department that rely on cures data for their licensees and to regulate, both wanting to go across state lines to fulfill the information that a patient or a prescriber, really a prescriber should have at the point of prescribing. We have a meeting set up for next week to discuss it with not this bill, but a different bill where we believe we could have a chance of putting an amendment in. But that one, because the Department of Justice is so concerned about it, is probably not the best. This is not the time. We're going to have to keep working and educating with them. Meanwhile, I'm working with another state that is also in the same position we are to find out if there's a way we can build some kind of system, and I'm using the department's IT folks to do this, if there's some way we can develop additional safeguards to encrypt the data or do something else with it to protect our data in California, because there is no reason in this world why the Board of Pharmacy is going to want to advocate a system that is ultimately going to compromise the Department of Justice's computer system. There must be a way to do this, so we're trying to talk to the right people to kind of help reduce the anxiety.
So it's the Attorney General's office that we're working with.
Well, among others. We've got the medical boards involved. We're working with another state office.
Ann wanted to say something also.
I was just going to say, as part of our support letter for this measure, we can include the board's policy desire to have the expansion of the cures and kind of provide some of the parameters so that the legislature is aware of the board's policy in this area.
So I'm certainly not suggesting an end run, but
It won't happen without working with them anyway.
okay, legislation you mean?
We need legislation to do it, to authorize it, but I think the real issue right now is the Department of Justice is going to have to come to a different conclusion right now.
Well, it's certainly worth pursuing.
And the board has invited the Department of Justice to come back to the board's next meeting and have a discussion so that we can resume and keep that dialogue alive, because that may be what it's going to take in order to do this.
Talked about this yesterday.
We did, yeah.
Yeah,
Thank you.
thanks, Jenny.
Okay, moving along. AB 182, Heroin and Opioid Public Education Act. The measure would require the Department of Healthcare Services to develop and implement an education campaign to combat the growing heroin and opioid medication epidemic in California. The committee noted the board's communication and public education committee's education campaign under development. Our committee is recommending a support position. Are there any comments by the board? Any by the public? Okay, all those in favor of the support position? Thank you.
That wasn't,
Unanimous.
okay.
Yes.
I'm sorry, I missed a few hands up.
Next, AB 208, deferred entry of judgment, pretrial diversion. The bill would change the deferred entry of judgment program to a pretrial program and would expand the conditions under which someone would be eligible for the program and reduce the conditions under which someone could be removed from the program. It would also reduce the length of the program compliance to 6 to 12 months and prohibits information sharing once someone is in the program. As part of our discussion, we discussed concerns with the measure and how it could undermine our consumer protection mandate. The committee was advised on an analysis of administrative cases closed in the past 3 years that involved an arrest or conviction, revealed that 119 of these cases would have been eligible for the pretrial program being proposed under the bill. In each of those cases, the board would need to prove the arrest and underlying conduct. Because of the challenges this measure presents, our committee is recommending an oppose unless amended and offer amendments that would restrict healthcare professionals from being eligible for a pretrial diversion program. It's in the Assembly Appropriations Committee suspense file. Are there any comments by the board?
Well, in the printout here, it says support, doesn't it?
Yes. No, I mean it's oppose. I'm sorry. It's oppose.
Oh, you
Supposed to be, but-
oppose unless amended.
Oppose unless amended. Are you on the same bill?
Yeah, look at this.
Are you working with a different version?
Mine says OUA.
On 208 here,
Yeah, oppose unless amended is what I have.
it says oppose unless
What's wrong with you
amended.
guys?
You've got a special, excuse me, you've got a special packet down there.
Good. What is this? Draft.
Oh, this one says draft.
You don't
on it?
have the-
Okay. Why would they give me a draft? Okay.
Because you're drafted.
Oh, all right.
Okay.
Good.
Oppose unless amended. So we have a vote. We had our vote.
Public comment?
Public didn't want any comment.
Okay.
Oppose unless amended.
Are we voting?
Voting.
And the vote is unanimous.
We're voting. Is everybody?
Voting, Ricardo? Yeah.
Thank you. I'm happy now. I've seen everybody's hand up. Thank you.
Okay. Just want to
Guys
see
led
all of
me
us raise
astray.
our hands.
Okay.
Okay, AB 315, Pharmacy Benefits Management. This bill would establish a regulatory framework for PBMs. As part of this framework, PBMs would be licensed by the board. During the March board meeting, the board took a support position on the measure. Isn't this dead? Okay. Okay. During the meeting, the committee heard public comment about a letter issued from the Federal Trade Commission regarding the regulation of PBMs by the Mississippi Board of Pharmacy. As included in the meeting materials, since our meeting, staff and council reviewed the letters from the FTC referred to in the meeting and note a few items in response to the public comment, and noted that the FTC letters offer opinion, not legal conclusions. Further, although the FTC notes potential conflicts, the opinion offered is very general and appears unsupported. Staff questions how a pharmacy or pharmacist entering into a contractual relationship with a PBM is different from a contract with a drug wholesaler or manufacturer to purchase drugs, where such a conflict has never been identified as problematic. Further, the FTC letter could be read to imply the need to protect PBMs from regulation, rather than focusing on the anti-competitive effects of such regulation, which is under the jurisdiction of the FTC. The concerns raised specific to the Mississippi Board regulation PBMs identified by the FTC do not exist in SB 315, and as such are irrelevant. It's referred to Assembly Appropriations Committee. Yeah, we already have a support position. So.
Yeah, I know. I'd like, either Josh or Laura to elaborate, if you would, regarding the recent update issue and the FTC. I mean, it's not a legal conclusion, but do they ever do legal conclusions, and their opinions are enforceable? And
I was the letter that the letters that were provided were unlike anything I've ever seen before, where the FTC was sort of stepping in and opining on state legislation. So I'm not aware that the FTC has that kind of official role typically. I'm not sure if that's what you're asking or something different. These were not these were not enforceable law of any sort. They were sort of, and the one that was on the California, related to the California statute, had not even looked at the California bill. It was sort of assuming that it was similar to the, I think, Mississippi bill that had been reviewed several years earlier. So
was it the FDA we were talking about their opinions as opposed to their conclusions, or
It was FDA.
So is FTC different than FDA? It seems to me that the opinions of the FDA were things that we should be concerned about because they do enforce their opinions, even though they're not conclusions.
right. Well, I mean, I think the best way to understand it is that neither of those is affirmative law. However, unless challenged, the FDA does tend to be more guided by those kinds of formal guidance documents. This was not a formal guidance document, so this didn't even go through the procedures that the FDA goes through to do its formal guidance documents. Even formal guidance documents are not affirmative law, and they say that all over the place, although they still do guide their discretion.
Mm-hmm.
So, but it doesn't really come to a head very often where if the FDA does follow its guidance document and therefore takes action against somebody, does that mean, if that's an extension from either a statute or a regulation, could they be challenged on that? I believe they probably could, but I don't think very many people tend to do that. But this was several levels below that. This was just sort of a letter written by an in-house counsel at FTC.
So at one of our meetings, we were warned, I guess is a good word, although I thought it was more than a warning, that
threatened?
that
I mean, the one
I remember that.
Yeah, so I haven't.
anyway, so we were warned that significant consequences could come upon.
Right, and
us
that's referring to this
individually or
North
as a-
Carolina Dental Board
Right.
decision.
Potential, yeah, the concern is that there's potentially anti-competitive conduct that could occur.
So there was a warning from a stakeholder.
Mm-hmm.
And so is there real concern with regards to the Attorney General's office that could materialize into a reality? And if so, how would you perceive the position of the board as a group and as individuals?
Well, it's not primarily my job to advise you guys on those kinds of personal liabilities issues. That would really be more DCA Legal's job. I can just tell you my own personal opinion about it, if that's helpful to you.
No offense to Laura.
Yeah, and
I've always been
I actually haven't
comfortable with
seen that letter, so I can't give you an opinion right now, but I can look at it.
Well, I think he's asking more generally about the North Carolina Dental Board stuff. So the North Carolina Dental Board was a very particular set of circumstances that some of which overlap with California's regulatory scheme, some of which don't. And even so, all that opinion said was that there is a state actor doctrine that provides immunity against antitrust liability that could be overcome if a certain set of that liability, that immunity would not be afforded to state actors under certain circumstances. It does not mean that you're automatically subject to antitrust liability. That's just sort of the immunity stage. And then beyond that, you have to go on and prove that there was anti-competitive conduct, that there was a market that was affected by, all these kinds of things that you have to prove to make an antitrust case. So I think the best thing you can say about North Carolina Dental Board and or about the FTC's, efforts to sort of trumpet it, is that yes, there's an immunity that everyone had assumed would apply to people in positions like yours that are state actors that under certain circumstances may not apply. So to that extent, I guess there's a slightly increased risk of antitrust liability. But you still have to be first committing anti-competitive conduct in order to have it. Not everything you do is not anti-competitive. The thing that was at issue in that particular case was that the dental board in North Carolina was sending out cease and desist letters to persons who were doing teeth whitening services where the state law didn't specify that only dentists could do that service. So it was more clearly, trying to shut down a particular market segment in favor the licensed market segment. So that's much more clearly anti-competitive conduct than anything we're talking about here. So my best prediction is that I don't see anything in what we're talking about here that is any kind of anti-competitive conduct.
Thank you.
And I would concur that, and I think I gave that advice at the last board meeting, that I don't think that the regulation on its face, and I say regulation not in terms of the California Code of Regulations, but the Board of Pharmacy's ability to monitor or enforce laws relating to pharmacy benefit
PBMs,
managers, PBMs, would necessarily trigger your liability in that regard. And I agree with 100% with what Josh said, that the North Carolina case does stand for that primary proposition about basically when a state agency can get out of litigation. So the Federal Trade Commission issued a citation to the and took action against the North Carolina Board of Dental Examiners. That's how that action started. And then it kept going and kept getting appealed. So.
But again, we have a whole different set of variables.
Totally
to even get there. And
different,
this
yes.
board is comprised of a completely different set of individuals who are appointed by under a completely different set of principles, and whose primary mission is protection of the public, and it's mandated to that.
And I want to say one thing about antitrust. Antitrust is a very fact-intensive analysis in any circumstance. So I think it's sort of loose and sloppy lawyership to say that, oh, well, that was a board that was comprised, had a majority of market participants. In that case, it was dentists. And this is also a board that has a majority of market participants, in this case, pharmacists. So therefore, those are wholly equivalent. There's lots of differences about how those persons were appointed, from which market segments they came from. All those things are very important in terms of the minute analysis that's actually required for determining the affected market, the affected market participants. I mean, it's all boring lawyer stuff that you don't really need or want to know about, but it does make a big difference. So I think we shouldn't overreact to North Carolina Dental Board. It's important to keep that in the back of your mind, particularly where you might be trying to shut down an activity. It primarily affects if you're, and not just an individual. Like, it's clear that it doesn't apply to individual licensing cases, like someone, if you put one person out of business because of disciplinary action, that even though you're, taking someone out of the market, that's not, it has to be essentially a class of persons that are being affected by some conduct that you're engaging in.
Bottom line is, we're not guilty of anti-competitive activity, so we shouldn't worry.
Well, I mean, I can't. You're at this very moment, you do not appear to be guilty of anti-competitive behavior.
Although the accusation.
What time is it?
Yeah. Yes.
Mr. Lippy, I do feel compelled to have to, since I was the one that represented the board at this hearing, this board was accused of being the fox in charge of the hen house multiple times.
I was told that, but they were wrong.
I agree, and we attempted to make that point.
Okay.
Oh, before we go on.
I need to ask for additional board comments.
Exactly.
And then I have to ask
Yes.
for public comment.
I would like to know, is it, as I understand, this passed the committee, isn't it? And also, as I understand, it been watered down. So do you know what it is?
The author's office is going to make amendments into the bill, I understand. I don't know when or what those amendments will contain. They're working to try to do this. PBMs have a major role in the delivery of medication, as everyone in this room certainly understands, and they're unregulated. And so there are 2 bills in the legislature right now that I'm aware of that deal with this. And there may be regulation this year, there may not be. The bills, should they even get to the governor, may not be enacted. So or, the governor could veto them. And we're a long ways from getting the bills to the governor's desk. The board has taken a support position on this, indicating that we believe we are ready and willing to regulate in this area, and we would be good regulators. But that's up to the decision of the legislature first to get that bill through to the governor, and then it's up to the governor to move from there.
So the author has not done anything yet to take out the language that would make the board at least an overlapping regulator
Unless
of the
the bill was
PBM.
amended in the last couple of days, no.
Okay.
But I know that they're looking at amendments. What they're going to do, I do not know.
Are we willing to accept that responsibility?
You did when you voted support on the bill.
And I would reiterate that, but there's been talk about the overwhelming responsibility that could become.
Well, our mandate is consumer protection. I think it's pretty clear in the area where you've got a series of 3 entities that control the marketplace, and the consumer really doesn't have a lot of redress. I think that we've run into situations where we get complaints involving the actions of a PBM, essentially providing pharmaceutical delivery of various kinds of services or products. That, to me, is the practice of pharmacy. That's pretty straightforward. Some of the ratios and some of the other materials they want available to the insurance companies and those that select which PBM is going to take care of them, that actually is more of a business function that we currently don't provide because it's not in our mandate to get into that space. Down the road, if we should be assigned that responsibility, probably coupled with that would be the ability to hire the appropriate staff to make those decisions, and then to establish appropriate parameters, and we'd have to do it in regs, to make those requirements there. The one advantage we've got over the Department of Managed Healthcare is we have to do everything in public. The Department of Managed Healthcare operates as a program within the administration. They don't have to do things in public. They can have meetings and develop policies. When they develop a reg, it would still have to have public comment, which is different. We sit in here and we go through the, as I call it, messy process of developing regulations, where you're talking about whether or not a particular term needs to be in there or not. That, coupled with our consumer protection mandate, puts us way out front, and it shines the sunlight on what we're doing with respect to the regulations. So, but we're a long ways from having a bill on the governor's desk, and it's not our bill. We support the bill.
But that was well said. Thank you.
Okay,
Are you
so-
guys all done now?
Yeah.
Yeah, I'd like
Getting-
to.
Alan was ready.
Alan's turn.
I get the impression you have something to
I do
say.
have something to say, and it follows with Jenny's mandate of consumer protection. In this paragraph, it says staff questions how a pharmacy/pharmacist may enter into a contractual relationship with a PBM that is different from a contract with a drug wholesaler or manufacturer to purchase drugs, where such a conflict has never been identified as problematic. And I find that sentence problematic because the contract between the PBM and a pharmacy and the contract between a wholesaler and a pharmacy, the contract between the PBM and the pharmacy restricts free communication from the pharmacist to the consumer, whereas the consumer trusts the pharmacist to tell them the best price for accessible medications. The PBM insists that the pharmacist not relay that information. I think that's indefensible. Indefensible.
So,
and so
Practice of pharmacy.
So I think that what the intent of that statement was getting to, people are saying that the Board of Pharmacy should not be regulating PBMs because there's an inherent conflict between the two of them, but a similar construct exists.
Oh, yes, and I want to point out the difference in the construct, and I think that difference in the construct is immoral.
Yeah.
And I like that comment.
A good comment.
Ellen. Well said.
Thank you.
But how do you really feel?
I want it in caps.
Okay, are there any public comments? Okay. Moving right along, we have.
Take a vote?
No, we already have a support, and the bill
We
hasn't
already-
changed.
yeah, we already have a position. We have AB 602, non-prescription diabetes devices. The bill would require pharmacies that dispense non-prescription diabetes test devices pursuant to a prescription to retain records require the board to post the names of authorized distributors of such test strips, and would make it unprofessional conduct for a licensee to seek reimbursement for such devices under specified conditions. As a committee, we contemplated if the board should seek the ability to embargo such counterfeit products, as well as if the provisions of unprofessional conduct should include purchasing such products from an unauthorized entity. We recommend a support if amended position with amendments to establish authority for the board to embargo counterfeit products found in a pharmacy, as well as specify that it is unprofessional conduct to purchase these products from an unauthorized source. The measure was on the Assembly Appropriations Committee consent calendar yesterday. So we have a support if we recommend a support if amended. It's on the consent calendar. So anyway, any board comments? Any public comments? All those in favor of support if amended? Unanimous? Thank you. Okay, these next measures failed. The legislative deadline will not move this year. It's AB 703 and AB 835. So I will not say anything more about those unless there's questions. AB 845, cannabidiol. This bill would, if federal law changes, authorize prescribing and dispensing a controlled substance prescription that contains cannabidiol. As part of our discussion, we noted that in its current form, the measure would prevent a pharmacist from exercising professional judgment by stating in the statute that it shall be deemed for a legitimate medical purpose. Council explained the consequences for such an approach and how it runs contrary to the board's enforcement efforts, and staff noted the significant effort the board has taken to educate licensees about corresponding responsibility and that the measure is contrary to the board's policy in its current form. Our recommendation is to take an opposed unless amended position on the measure and request staff to offer amendments that would allow for the policy goal without undermining a pharmacist's corresponding responsibility. The status is it's on the Assembly's consent calendar. Any board comments? Any public comments? All those in favor of an opposed unless amended position? Unanimous. Thank you. Next is AB 912. This bill would require a state agency to provide assistance to a small business in achieving compliance with laws and assist the business during an enforcement action. It would also require the state agency to establish a policy to waive civil penalties under specified conditions. During our committee meeting, we noted that this measure creates some conflicts for the board and its mandate, especially as it relates to the dual role the board would be required to play during an enforcement action. Such a conflict may be a violation of the Administrative Procedures Act. Committee is recommending an opposed unless amended position to seek a way to remedy the conflict. The committee agreed that assisting small businesses with licensing requirements is appropriate, but questioned the need for a mandate to provide such service. It's been referred to Assembly Appropriations Committee. And any board comments? Public comments? All those in favor and opposed unless amended position, raise your hands. Thank you. Unanimous. Next, SB 17. The measure is intended to gain transparency into drug pricing by establishing reporting requirements for prescription drug cost and volume for health plans, and reporting requirements for drug manufacturers in advance of drug price increases. As committee, we noted there is great need to reduce the cost of prescription medications and noted that a patient cannot receive the benefits of a prescription if he or she cannot afford it. Committee also noted that this measure may be a first step in helping to make prescription drugs more affordable, and as such, we recommend a support position.
It's just the report that this bill refers to. So is that something that would be available to this board and the public, or?
So there is some public reporting. It is aggregated data, but I believe under the provisions of the measure, the aggregated data cannot be so aggregated that you can't tell the drug.
Okay.
Guess I'm not clear exactly what it's going to report.
Yeah, so in the measure, it details out all of the different provisions that they need to do.
So if a consumer were to go on a website or whatever, what would they find that would help them lower their cost of their medication?
This is not, so this is really, this measure is about transparency of drug pricing. It's not for a consumer to say, if I go to this pharmacy, this is how much I'm going to pay. This is about understanding how the prices of drugs get there. And so the provisions talk about, I don't have it totally in front of me, but the provisions talk about the fact that you need to report certain elements with respect to either the Department of Managed Healthcare or the Department of Insurance, and I believe it's targeting like the top 25 of the drugs, the sales volume, the prices, and then there's notification pieces in there where if the price of the drug is going to go up, there's a pre-notice requirement, and then you have to document why the price increase is necessary. Is it because there's improved efficacy? Is it, you have to, there's a justification.
You're not, by price, it's not really what the consumer pays, it's what the health plan would pay.
It's not what the consumer would be paying at the pharmacy transaction, but I'm sure that it's what the consumer is paying from the big
It's
picture.
looking at acquisition drug costs to health
That what it
plans.
is,
Yes,
yeah.
yes. The
So
whole
once
point
again, it's
is
what the
to,
health plan
yes.
pays, not what
Yeah,
the patient pays.
there's been
That's
several.
carried on to the consumer.
Yeah, there's been several, provisions over the last several years, several measures that have really been designed to reduce drug costs, increase transparency. This is getting at the transparency piece, which I believe the approach is get the transparency, understand it, and then go to the next step.
Okay, it's scheduled for a hearing on May 8th in the Appropriations Committee. Any other board comments? Any public comments? Okay. All those in favor of support position on this? Thank you. Unanimous. Next is SB 27. The bill would require every board within the Department of Consumer Affairs to grant a fee waiver for the application for and the issuance of an initial license to an applicant who served as an active duty member of the California National Guard or the United States Armed Forces and was honorably discharged. The committee noted that the board had a support position on a similar measure last year and is recommending a support position again. Any comments? Public comments? All those in favor of support? Unanimous. Thank you. SB 641. The bill would limit the conditions under which a law enforcement or regulatory board may access cures and would establish a multidisciplinary advisory committee to assist, advise, and make recommendations for the establishment of rules and regulations necessary to ensure the proper administration and enforcement of the cures database. During our meeting, Council expressed concern with some of the provisions in the measure, including challenges with law enforcement gaining access to the information needed. Staff also expressed concern with stakeholders developing policy recommendations on the appropriate administration and enforcement of the cures database. Staff suggested that amendments could be offered to address the concerns by removing those provisions. Since our meeting, board staff has been advised that as written, the measure may require the board to secure a warrant every time it requires information from the cures system because of the way the measure is currently constructed. Staff notes that if true, this would create a significant barrier to board investigations and would further create a significant fiscal impact to the board. Staff notes that the board does not use the information in cures to investigate individual patients and questions the policy behind requiring the board to obtain a subpoena to access information in the cures system that is reported by its licensees. The committee's recommendation is opposed unless amended. The status is that the Senate Appropriation Committee hearing scheduled on May 8th.
Can I just add one update or new piece
Sure.
of I just happened to attend yesterday. There's a case pending before the California Supreme Court that is a challenge to the cures system on privacy grounds by a medical doctor. And so I attended the argument yesterday and I mention that only because, not that I run the world, but if I had my druthers, I don't think that we ought to be amending the cures program with regard to privacy protections right when that very issue is about to be decided by the California Supreme Court. So in my own view, and it's reading tea leaves, but as far as I could tell, it seemed very likely to me from the argument that the Supreme Court is going to uphold the current construction of cures against a privacy challenge. So to sort of gratuitously add additional privacy protections that the court may not deem necessary seems to me like a little bit of unfortunate timing.
So you're feeling we should oppose instead of oppose unless amended?
I don't make policy recommendations. I'm just telling you what the
reading between the lines. Well, the committee says oppose unless amended.
What was the criteria for oppose unless amended?
Well, because we felt that we could amend things to make this more tolerable. So
based kind of on what Josh is saying,
Yeah,
it
I
sounds like
think-
maybe we need to change that to oppose, but we have to vote
but
this
we
down.
have to vote this down first. But
Well, I didn't. That's not what I meant to be saying. Sorry, I didn't. I was just providing some additional context. I was not intending to affect the committee's recommendation in any way.
It's useful information.
Yeah, and I will say that the language of this particular bill if our amendments were taken, it would have some additional advantage to the board in terms of making it clear that the board is allowed to use that data for regulatory purposes. So there are both pros and cons to this particular bill. So.
Okay. Any public comment?
Well, I
first
just
of
want
all?
to ask, does our staff have an opinion?
Staff opinion.
The only thing that I would say is sometimes it's a stronger position to take an oppose unless amended because you can try to affect change on the measure. Oppose, it generally just means that this policy is so totally flawed. We just so totally disagree with the policy. We just can't. There's no way it would ever become palatable. I think that there are some things that we could offer that would then make it maybe something that the board could either support or go neutral on.
And the thing is, if we say oppose unless amended, we're not saying what the specific amendments are. So I think it leaves it open.
So we've kind of we've said what they are, right?
Well, we know what they are currently, but
It's
that
important that
doesn't
we
mean they're gonna-
articulate the board's position in the letter.
Yes, I concur. If you're going to take an oppose unless amended, you want to say generally what it is, not maybe
Okay.
specific language, but you do want to send the message
Okay,
of what the
well,
policy is that you're trying to further.
Before we do anything, let me get public opinion if they want it. Anybody want to say anything? No? Okay. Now we can come back. So the
Motion to
question
change
is-
our position to oppose.
No, I think
Well,
we
have to
should
first
leave it.
vote down
It's my
this.
motion.
Well, I think we need to vote.
have
We
a
need to vote on
motion
the
already.
Need to
committee's
vote on the
recommendation.
oppose unless amended. So all those opposed to oppose unless amended, raise your hand.
No, you
No,
want us
we
to
support-
vote. We need to support the committee's recommendation.
No, because it sounds like everybody wants to go against it.
No,
I'm not
no,
so
we
sure
first
that's
have to
true.
vote this down.
And you've got a motion in front of
All
the
right,
board.
so all those in favor of supporting the committee's OUA? Raise your hand.
Committee? Yeah.
Supporting,
Unless amended. So it's
Oppose
oppose
unless
unless amended. Yes.
want to support the oppose unless amended?
Yes.
There are 9. Okay, so there's 9 votes.
Weird.
No, it's 8-2.
Wait a second now. I have a valid vote here.
Yeah, 8-2.
Yeah, well, I'm against it.
Okay, that's
So
two.
oppose the committee's recommendations too. Okay.
Okay, so it stays as an OUA?
Yes.
Okay. So Josh's comment didn't sway anybody except me and,
As is the usual.
me and Stan. Okay,
See what happens in my house.
yeah, okay. SB 716. This measure was recently amended and in its current form would increase the number of board members to 15 by adding 1 pharmacy technician member and 1 additional public member to the board. Both members would be appointed by the governor. The measure was amended after our meeting. It originally called for 1 technician member and only 14 total members, and we stated that that was a problem having an even number, so now it's been amended to 15.
So
And
this bill come from?
Yeah, why is
Well, I
this
think
being
we have
brought
the
up?
sponsor in the room.
So
I
it's
think
being
Valerie can tell
sponsored.
us where it came from.
Well, it's being sponsored by CSHP, and the The sponsors have indicated that given the board's licensing population and the fact that there's 72,000 pharmacy technicians, that they should have a presence and a representation on the board.
Okay.
Should say morning or afternoon. Good morning, Lori.
CSHP is really pleased to be able to sponsor this bill. It's really an attempt at getting a voice for pharmacy technicians. There are actually 10 other states that have pharmacy technicians on their board of pharmacy, and none of those states, and we're counting Texas amongst them, come even close to the number of pharmacy technicians here in the state of California. When it was heard prior to, we had a request from the Senate Business and Professions Committee. They were concerned, and it had to do with the Supreme Court decision with North Carolina, and it's actually in the bill analysis, that they would support an addition of pharmacy technician to the Board of Pharmacy, but it actually had to be accompanied with also a public member, which brings your total board to 15, which, by the way, is what the Medical Board and the Dentistry Board currently has as well. It passed out unanimously, and we have our appropriations meeting on Monday, Senate.
And CHHPs,
Close enough.
What does CPHA stand on this bill?
I don't know if they have a position on the bill.
Oh, we're going to find out.
Wait, what was your question, Stan, though?
well, so your feeling is, or your organization's feeling is, that they should have a voice for what purpose?
Well, they are regulated by the Board of Pharmacy, but also additionally, we believe that we haven't kept up as a society with the requirements and the practice of pharmacy technicians, and really to fully actualize Senate Bill 493, we need to also increase the level of expectations and qualifications on our pharmacy technicians. So we're having more pharmacists coming out from behind the counters and the computers. In my understanding, we haven't touched regulations regarding pharmacy technicians for about 15 years.
But you are aware that the licensing committee is very involved in
Yes.
and so you feel that their input would be critical at this point with regards to consumer protection.
Absolutely. And there is a precedent, and we did consider this. There's a precedent to establish an autonomous board for pharmacy technicians, given the sheer number of licensees. That precedent was set with the Physician's Assistants Board, which is a 9-member board, and they oversee about 11,000 licensees. And you also have the Dental Hygienist Board, which is also an autonomous 9-member board, and they oversee 22,000 licensees. Pharmacy technicians numbering 72,000 could warrant a board in itself, as modeled after the physician's assistants as well as the dental hygienist. But we thought that this was a conservative approach to not grow government, and also to keep pharmacists and pharmacy technicians linked at the regulatory oversight perspective.
And does part of your organization's membership include pharmacy technicians?
Yes.
So the outcome is going to be, in the event that this goes forward, that there'll be 7 professional members, 7 public members, and a pharmacy technician.
I would say that there are 8 professional members and 7 public members.
We have some input from, is your CPHA?
Correct. Michelle Rivas with CPHA. CPHA was supportive of the bill as it was introduced, but unfortunately with the amendments to add an additional public member, we had to withdraw our support for the legislation. We have not filed a new official letter, position letter to the committee. We are having discussions with the author's office as well as the sponsor. So again, we were in the unfortunate position of having to withdraw our support of
Why? Why did you have to withdraw support because of another member?
It was the additional public member that is concerning to us, and while we respect the role that the pharmacy techs play, I think the characterization that that person would be seen as a professional member of the board along with the licensed pharmacist is something that our leadership has some concerns about, and we think warrants some really thorough discussion around that issue.
Okay.
Good morning.
Good morning. Hi, Paige Talley with CCAP. And CCAP has taken a support position on this piece of legislation. We like the idea that a pharmacy technician, clearly with somebody who's had 5 years experience in at least 2 practice settings, and they have to have medication reconciliation, all kinds of things that are vital. They're not just counting pills and having the pharmacist check it. Techs, we've found, are really bright people. I mean, we have our technician on our board is our treasurer, and he has an MBA. So I think they're of value. They have a lot of patient experience. I mean, they're typically the first person you see when you walk into a pharmacy. So as an advocate for consumers, I think they deserve a seat at the table. I'm sorry, but I'm
Thank you.
finished.
Thank you, Paige.
Sorry.
Thank you.
Okay, thank you.
So I'm full support of technicians becoming more active and having a greater role. I just don't know if putting another technician member on the board is going to accomplish that. I think it's going to be done more by the discussions that the licensing committee is having on expanding the role. I'm not sure that
The
placing
committee recommends a support position, but
I'm with Amy and Stan. I fully support technicians and their contribution. However, I don't support the number of increasing the number of board members. Getting a quorum will be more difficult. I do not believe that pharmacy technicians have experienced the degree of sophistication that is necessary. For the rules and regulations that we have passed, I look on, has it been necessary to consult a pharmacy technician to give me any advice on any of the legislature, on any of the rules, on any of the regulations that we've had? And I can't come up with one example. The fact that we are totally responsible for the technician, that everything that they do is under the pharmacist's purview, does not, it's, the logical structure.
Well, they're not acting independently, and I think that's the difference.
Yeah,
With
yes.
PAs, they can. I mean, this is not an independent discipline.
Right. And also, if I look to, they mentioned the other boards, the PA board and the dental board and the PAs. Those are pretty intensive educational programs, and they make individual decisions on when they do their procedures. And the analogy that I come up with the medical board is, the physicians, every physician you go to has a medical assistant that comes in and takes your blood pressure, etc. I can't imagine, and there's thousands and thousands of those, much like pharmacy techs. I can't imagine the medical board having an MA on their board. And it takes about the same amount of education. So I'm not in favor of this for a variety of reasons. I hate to oppose CSHP. I hate to oppose something that Senator Hernandez supports. But I can't support this.
One of the things, so the first thing that comes to my mind is we have never said a technician couldn't be on the board. We actually have a public seat open. So I think that actually a technician could be on the board today.
Oh, on a public seat?
As a governor appointee.
On a public seat. I mean, I don't even think it has to be as a governor
There
appointee
there
or
may
as a
be a
public member.
limitation
As a
that
public member.
It's just that this would mandate it, and
Laura, can they be a public
I
member?
actually, give me a second to look it up, but I actually
don't think
believe
they
that
can.
public members specifically have to not be involved in the area
Oh,
of
in the
practice,
practice of
so they
pharmacy?
may in fact be prohibited.
I just have a comment really quick. Just playing devil's advocate. For example, you had made the comment that, you know, a pharmacy technician, you have never taken any type of direction or I guess information or knowledge based of the type of information that we use in all of the public policy. If you look at that as well, I understand like there's a public member. I am not a pharmacist. I do not have the expertise, but I bring a completely different type of viewpoints as a consumer to the pharmacy world and so forth. So if you look at a pharmacy technician, and like I said, I'm trying to understand, you know, why would it be such a disadvantage if a pharmacy technician has the ability to work in a facility or a consumer in a facility where the consumers of pharmacy are in on a daily basis and bring that perspective to the board. Just like public members are put in this board to bring a completely different, we have a law enforcement, myself who works in optometry, part of the medical field, but yet it's not a pharmacy in general. We have a certified an accountant here. So it's a broad understanding so that us as a board, we have to open our eyes and take the initiative to see how can we better, how we can provide the consumer protection, how we can bring individuals that can speak on behalf of the experiences they have of all areas and to then provide a better policy that will protect our consumers in California. That's what I have to say.
Oh, no,
I agree with that.
And I agree with you. You guys are the public members, and so are you. So
unfortunately, though, at this time, because of a public member, and I believe that the attorneys are looking into that a technician is not able to serve as at that particular. So at this current time, the way the legislation is written, they aren't able to serve on the board.
I beg your pardon?
Is that correct? Is that what my understanding is?
I'm looking it up right now.
So that may be that.
But that doesn't.
Professional member.
It would be a professional member.
That doesn't prevent them from coming and testifying before the board. And I kind of agree with what Alan said, that aligning them with a physician assistant or a dental hygienist that requires at least a bachelor's, if not a master's degree, that it's a different category that they.
It sounds like the issue is that they would be considered a professional member, and the profession doesn't think that they have the sophistication to be a professional member.
But I think if they are a professional member, does that, and I guess a question to Laura, can the governor appoint a pharmacy tech
that's
as a
what
professional
that's my
member?
next comment. I said
the governor-
I would think that there's no stopping them from appointing a technician. We don't have to create another position. but
Can they
They
do
could
that?
appoint it.
They
can't
can't.
appoint
As a public
pharma
member?
tech?
No.
They can't as
There's
a public member, and they
there
don't
is a-
qualify as
Why
a
is that?
There's a
professional.
business and profession code sections, there's a series that apply to public members and determine who qualifies to be a public member. And as part of those qualifications, the public members have to not be in a contractual relationship with the licensee of the board, can't be an employee of a licensee of the board or a representative of an employee. There's an infrequency exception there, but in addition, they can't be a current or past licensee of the board, and they have to have a 5-year gap. So perhaps a former licensee, or they can't be a close family member of a licensee of
How
the
about a
board.
professional member? Can a farm tech be a professional member?
Apparently not, otherwise there's no one
So
to be
I
there.
would, to me, I use the word professional. I think of every member on this board as a professional because we would expect you to behave professionally. So I think of licensed members and
Right.
public members in my mind. But there
I'm
there
just going
is
by
a
the
distinction.
definition and the regulations, yeah.
So our statute says the governor shall appoint 7 competent pharmacists. So we don't use the term professional. It's 7 competent pharmacists to reside in the different, et cetera. And then it moves on to say that the governor shall appoint 4 public members, the Senate rules and the Speaker of the Assembly shall each appoint a public member who shall not be a licensee of the board. So there's where the prohibition is specifically in our code.
So there's no seat available for tech at all?
Right.
That's, what, 7 to 6, 7 professional and 6
That's the current
non-professional?
composition of the
Yeah.
board is 7.
Right.
Yeah, so, I would prefer that, the board consists a majority of the professional member. So if you add another non-pharmacist, it would be 7-7. And also it's an even number.
No, this calls for it to
15.
add an additional member, so there'd be 15 total.
So it could be
So it would be an
another
additional
professional member?
professional member.
No, I thought the amendment said that it
Or it
would
would
be.
be additional public member.
Yeah, so,
Because the technician would be considered an additional.
right, so there'd be 8
All the
public.
materials say 14. Where did the 15 come from?
I
It
guess
was
they're recent
amended.
Adding one consumer
recently
member
amended?
and one
Yes,
tech.
it was
So
recently
13
So that was
plus
recently
2.
amended since the
Yes.
materials? Okay.
So
Just
there's
wanna
an
make sure.
additional
Our
consumer member
recommendation.
that's being added, and that's why CPHA.
So what you're saying is that
issue.
non-professional members are more than the professional member in the board?
Well, if you count the tech, could either be a consumer member or a professional member, or you pull the individual out as like a standalone representative. We don't have wholesale
This
representatives.
is the pharmacy board, it's not a technician board.
I mean, yeah, that's a good point, Jenny. I mean, we have other licenses.
But again, I think that the intent was they're adding an additional consumer member as opposed to a professional member to make certain we have an odd number of board members.
Mike.
Oh, I'm sorry. Am I so far away nobody could hear all that wisdom and it just got lost? Oh, whatever.
I just don't like the idea that you have a non-majority pharmacist in the pharmacy board.
I agree with you. So if we're going down this road, then we should add a technician and a pharmacist, not a technician and another consumer member.
I think, again, the mandate is consumer protection. So does it matter whether or not, I think the board needs to discuss this at some length because
Yeah.
it really is a major philosophical
Then we should not
shift.
call this a pharmacy board.
Okay, why don't we do the
Call
vote?
it the Board of Accountancy.
Greg, why don't we call for the vote? And
Well, have we heard from all the public members we're going to hear from? Okay, then we can go for a vote. The committee has a support position, so all those in favor of the committee's support position, raise your hand.
1, 2, 5.
okay, so do we have another motion?
Well,
Hold on. Sorry.
All those opposed to the committee's? So it's
5.
5 to 5.
Well, there we've got the motion didn't pass though.
So it's 5 to 5?
So the motion did not pass. So do we have another motion?
You not vote?
We don't need one.
No, we don't need one. We just need to make another motion.
Okay, so you don't want to have a motion to oppose, you just want to let it go.
What about a motion of oppose unless amended to address the issue of the additional member? The oppose unless amended to address the issue, because from what I understand, part of what CPHA's concern is that it's not only adding the tech, it's adding another public member. And I think that's what I heard from Albert too. So if we do.
Is that CPHA's? I heard that they were concerned that there's adding another member. Is CPHA, if it was a professional member?
I thought it was a recent
If it was a
change.
pharmacist member?
Yeah.
Amy, I don't think she understands the voting. I think we would like to have a revote.
A revote. Okay, so let's CPHA's position, as I understood it, you said, was it was supported, but it was recently amended to add in another public member.
Correct.
So you're,
CPHA was supportive of the bill as introduced, which would have added a pharmacy tech. We were supportive of that version of the bill, but when the bill was amended, that's when we withdrew our support.
and the bill was amended to add an
An additional public
besides the
member.
public pharmacy tech.
Correct.
Okay.
Correct.
That's what I thought.
We were
But I
supportive
thought you
of the
said
tech, but not the additional.
so what I was
public member.
recommending is
They were considering
oppose
a
unless.
pharmacy tech a professional
Yeah, well,
member.
I guess my comment was oppose unless amended. If it was that additional member would be a pharmacist, not a public.
That's not
member.
what she said.
Well, no, that's what she said happened.
She said they
No, but-
pulled their support because it was an additional
That's not
public
what they-
member.
That's not what CPHA wants.
If it would have been a pharmacy member, they would have supported it.
Right. I think the bottom line, Debbie, is I think the concern is that the concern I've heard
Then
here
it
is that it
throws off the
outweighs
balance
the pharmacist
the other way.
balance. Right.
Well, I think actually if you don't add the public member, then you have 7 pharmacists, a technician, and 6 public. So I think what CPHA is saying is they're okay with that.
Yeah.
Yeah, they were.
I'm sorry, I thought you were saying that the 15th member would be a pharmacist.
No, I
Okay.
was saying
Okay.
that
All right,
it
The
changes
fact is, we never have all members here anyway at one time.
I'm objective. If there's
Sorry.
if it's the pharmacist is not the majority of the board.
So I think, Albert, you had asked for a revote. Is that what you asked? If we could revote, because he said Cheryl didn't understand the vote.
So,
Laura?
Use your microphone a little better.
Okay. No, I agree with CPHA and that I'm okay with a tech and a pharmacist and not a tech and a consumer member.
Okay.
Okay. So,
So Laura, what do we need to revote?
so there's 2 options. One is you would move to reconsider your prior vote, and if that reconsideration, it sounds like you want to reconsider, then you revote on the same motion. You could alternately have a separate motion.
why don't we just do reconsideration?
Well, I don't think we need to because we voted.
I mean,
we
it
did,
came out the
didn't
same way
pass.
anyway. It didn't
So that's
pass.
just going to make it officially not pass.
That didn't pass
So I think why don't
anyway.
we just make a motion that,
Oppose unless amended.
and the amendment would
Be
would
to-
basically go back to the original.
Just adding the pharmacy
But then it
tech
throws the
without.
balance off the
May
other
I-
direction.
No, because then you have 7 pharmacists, 6 public, and a technician. So yes, we could have an even
But the
vote.
technician could be considered more.
Let's let
It'd
Laura-
be
I
one
think
technician
Laura's-
and one pharmacist that
Special.
added to the board. We would recommend that one technician and one pharmacist added to the board.
That's
I can't
different than the
support that.
motion that Debbie just gave.
Well, I didn't have anybody second it, so.
It takes,
What was your motion, Debbie?
takes
Proposal
away
as
the
amended with the,
benefit of
basically
the
going
public
back
member.
to the original language, so we would end up with 14 people, but it would be 7 pharmacists, 1 technician, and 6 public.
So just a question, the reason that the additional member was added, my guess, was
So we
because of
didn't
the
have
even
14
number.
even number, right.
Right, so we're still back to that issue then if we do basically.
Is that a motion on the floor or not? If not, I would like to
Why
make
don't
a
we just
motion.
leave it the
No,
way
I'm
it
just,
is?
I was asking a question so I understood it. Okay, so that's
Why
what
don't we
you're
just
saying.
leave it the way it is where it didn't pass?
We have the support of the Pharmacists Association, the major ones, about adding a pharmacy technician to the board, given that this board regulates their practice. And the fact of the matter is that the practice of pharmacy technicians is going to only evolve and grow, and it needs to in order to support advanced practice pharmacy here in the state of California. When we were working with the Senate Business and Professions Committee, and it's because of the Supreme Court decision of the FTC versus North Carolina, they were very uncomfortable with there being so many professional licensees, whatever you might want to call it, outnumbering the public members. And this was the way that which they felt more comfortable with passing this bill the way it was written. So it was originally pharmacy technician, take you to 14. They said you need to balance this out. We're really concerned about the Supreme Court decision. You need to add a public member. And then, of course, just real briefly, we did do some amendments that clarified the qualifications of a pharmacy technician so that they have broad-based experience. I mean, clearly, pharmacy technicians have an extreme range of what it is that they do across the spectrum of healthcare. So just for consideration, I don't know if how that's going to be received with the Supreme Court decision of FTC versus North Carolina and their concern about potential self-dealing.
Well, we have currently 7-6 right now, 7 professional and 6 non-professional right now. So we have no problem with it right now.
Can I ask counsel about does this FTC or the federal, does that have an issue? Does that have a relation in terms of the number of board members?
Well, yes, to the extent that the North Carolina Dental Board case, there were various factual factors that they that were at issue in that case. One of which was that the board had a majority of what they call market participants, dentists.
But in their analysis, I think they addressed the issue and they said simply providing a majority of public members wasn't going to completely solve the problem.
Right. So I don't think that's a dispositive issue. And again, there were differences about how those board members in North Carolina were appointed and who they represented that I think would distinguish this board. So I would not focus so exclusively on the numbers or the majority issue.
I think we should have a bill that says that the governor could appoint a technician, period, as opposed to this. That way, it takes away the need for everything. So maybe we could support, introduce legislation to that effect.
Or add this as an amendment. So you would want it to read to the effect that the Board of Pharmacy shall be comprised of at least 6 pharmacists members and leave the professional membership at 7. So the governor could determine, and it would be a governor appointment.
No.
No, it could be, it could
He
be,
could appoint the technician
No,
as
if
a.
you have 6 of the 7.
no,
then
the public member
appoint
could
the-
be a
as a public
technician.
member.
A public member could be a
Could
technician.
appoint the technician as a public member because they do not qualify as a pharmacist.
would that qualify though as a professional member under the other definition?
No, I think they're
That's
saying
why
as
we
a
asked to
public
change
member.
it.
No, I heard that,
As
but I think
pharmacist.
Laura's point is that pharmacy technician is too closely aligned to the profession to be able to be called a consumer member.
So,
That's
so I think
licensee.
in order,
My back
if,
hurts, sir.
is trying to tell you, and you're.
if the proposal is to convert one of the public member positions to make it sort of an optional tech
Technician.
position, I think you could do that through an amendment. You would, basically, the more specific law would control, so if a provision was added into the pharmacy law that says, notwithstanding the general provisions that specify what the qualifications are of a public member, a public member on this, one public member on this board or more may
Could be a
be a
technician.
pharmacy technician
So that
with
does
the following
offset the balance a little
qualifications.
bit, but at least we're not adding 2 more members.
But then you'll run into the issue with the North Carolina case because the technician is a licensee that the board regulates. So that you have one more majority. That becomes an 8-member licensee and only 5 public members. So I
Doesn't
think
say
that would be an
licensee.
issue.
It says pharmacist. It says
No,
that-
but the technician is actually regulate under this board as a licensee.
Correct.
Right.
That's the issue would be if you have 8 licensees and only 5 public, then you might have an issue right there.
Well,
But I think council said that doesn't necessarily
It's n-
relate.
yeah, it's not, so
Yeah.
there is significant, one of the concerns is that the decisions being rendered were being rendered by market participants, in other words, licensees. So that's in the North Carolina case, and that was one of the key factors in that case. I mean, there was a movement to kind of balance out boards so that you didn't have that, and I'm not that would still be an issue.
But do you know how many members of the board for the dental board were licensees?
I do not know. I mean, I could look it up. I know that there are
think
some
that
boards
matters.
within the department that have public member majorities, I believe.
so
that
what's
there
the
are
co-
a few.
You're talking about the North Carolina Dental Board. I believe it was similar to this current construction in that it was like a.
No, it was 7 professional members that were elected by the licensed members and 1 public member, I think.
What's the composition of the medical board?
Don't know.
Oh, no, our medical board come from.
I would have to look that up.
But the medical board, they don't have the physician assistant as licensees.
Yeah, but,
Am I
but the
correct?
difference,
Am I
Right, but I think
correct?
that
The medical board
How
only
many
consists
public-
of
how many
the
public and how many
medical
professional?
physicians. They will have professional members, they are
How many?
public. But they don't have physician assistant as
I
the
know,
licensees.
but
yeah.
how many professional, how many non-professional member?
But I think, Victor, the comment
might-
that was made before was that a physician assistant does not equal a pharmacy tech.
But physician assistant have their own physician
Careful.
assistant board, okay? But then our board of pharmacy, we do have, like I said, 45,000 of pharmacists and about 72,000 pharmacists as technicians. So in a way, if they have 72,000 people paying dues to this board, I hate to say it, in realities, we do have to give them a voice on the board.
Yeah, I would draw a distinction. It's not dues. It's not a membership. We're very different. This board is very different. It's consumer protections. Those are license fees compared to
Okay, but
dues
they're
of
paying fees.
association.
Well, can we change, can we suggest that they could appoint one technician and one pharmacist?
Well, we're beating this to death, and we're not going to make any progress here.
I agree.
Yeah.
And so let's do something.
Do we want to revote? Is that Chair Lippy, that you would like to do?
Well, if Cheryl felt
Cheryl
she
misunderstood
wasn't,
We're back at
the
the same
then I think we
situation.
just go back to the
So then, does anyone have a
reconsideration.
motion?
I would like to reconsider.
Does anyone want to make a motion on this? On our position on this bill? Because the motion we didn't get enough votes.
Okay, here's
say
I would-
here's the
unless
deal. The
amended.
committee recommendation is
Support
to
unless
support the bill, okay?
That was.
If you want to reconsider the vote, then we'll reconsider the vote.
I say reconsider. the
Let's
vote.
reconsider it
Okay,
just to
let's
get.
reconsider the vote. Do we have to vote to reconsider the vote?
Yes.
Yes, you have to have a motion and a
All
second
those
to
in
reconsider.
favor
No,
of
no, you have to have a motion and a
reconsidering-
second.
I would
first.
motion to reconsider the vote.
I don't think we need a motion, but
I think
we do?
Albert just made the motion. Stan
Okay.
seconded it.
Okay.
So all those in favor of
reconsidering.
reconsideration, raise your hand.
Just
To revote.
We're just
All
voting
on
to
the
revote.
revote.
the vote.
Okay, that's fine.
Opposed?
Okay,
Okay.
okay. Now,
Yeah.
all those in favor of supporting the bill, raise your hand.
Support unless amended.
All those opposed, raise your hand. Fails.
Oh, I'd like to support unless amended.
You would like to propose or make a motion
I would like to make a motion
of
to
oppose unless amended.
oppose unless amended.
With what type of amendment?
That a pharmacy tech could still be considered part of the 6
Public members? Is
members. Yes.
there a second? to
I second.
Cheryl's? Second.
So it would be an amendment, basically carving out an exception to the general
Right.
rule that a public member can't be involved.
Yeah, that a pharmacy tech could be a member of the public.
Second was Albert.
Okay,
Thank you.
do we have a second?
Albert.
Okay. All those in favor of oppose unless amended to make a pharmacy tech qualify as a public member, raise your hand.
Is there
Okay, all
opposed?
those opposed to the oppose unless amended. That fails.
Okay, so is there another motion that we want to take on this bill?
I think we just want to move to the next.
So it's just going to be
We're
opposed?
just gonna have no position.
Is our
You'll have
position,
no
is our
position.
position opposed and amended?
No, we have no
You
position.
guys, we can't have
You
no
voted that
position
down.
on a bill that's about our board.
We have to take a
That's
I agree,
where we
Debbie.
are.
This is a
I
bill
agree with
about our.
Debbie.
I agree,
We
Debbie.
have to take a position.
All
So
right.
is there another motion on this? Stan,
I
do you have any?
would motion to appoint a technician and a pharmacist.
So you want oppose unless amended and adding a technician and a pharmacist instead of a technician and a public member? Okay, is there a second to Albert's motion?
I second.
Okay, all in favor of this we haven't been asking for public comment. Public comment on this particular motion. Okay, all in favor?
All in favor
Well, I
of,
just kind of want a little bit of discussion. Because I'm kind of trying to figure out where we are here. So that would take us from 13 to 15.
Correct.
So
Right.
Cheryl's motion kept us at 13. This takes us to 15. and we add 2 people, one's a technician and one's a pharmacist. So I guess what's really the difference between the
But then you
prior
have
motion?
you have nine licensees.
No, we'd have 8 license,
No, but the
licensees, we'd have 9
licensee of
licensees.
nine
Why don't we kick
licensees.
the can down the road, have somebody from the senator's office come and explain to us why it is what it is, and then decide what to do then?
Well,
No, I think we need to
I
take a
think the explanation we heard from the sponsor is what we would hear from the committee consultant, provided one would even be willing to do that.
I would make a motion that we return, and I realize that there was some resistance with regards to, is it?
Right, Procedure Act? Business and
Whoever it
Professions
is
Code?
that reviews.
The Office of Administrative Law.
That's it, thank you. But I would suggest that we return to the original motion and the original bill that the
14.
that the Ledge Reg Committee supported. And that is adding 1 member, bringing a total of 14, and that member is a pharmacy tech.
Which was the original
Well,
bill.
I would probably be in support of that, but we already have a motion on the floor.
Okay.
Josh, would it be okay then?
We haven't
for
voted
8
on Albert's motion yet.
I need opinion from Josh and Laura. We have 8 licensees and 6 public member then if we increase it to 14.
Yeah, as I said before, there is no magic formula that will either give or not give antitrust. Remember, what we're talking about here is antitrust immunity, not antitrust liability. That's the second stage. So the court didn't provide, it said that, majority or non-majority was not the crucial issue. So
Yeah, most of the time, we all know not all show up anyway.
Yeah.
Well, I guess the
your
other thing we
immunity
need
is-
to take in consideration with that proposal is what Lorianne said, that the business professions, whoever it was, said that they didn't like the 7-7, that they're the ones who actually pushed that we should have 15.
And I referenced that.
You're on. Oh, you just, no, you just
You
turned
were
yourself
on
off.
before.
You just turned yourself off. Now you're on.
I referenced that in my motion.
Yes.
However, I think
You
that
did?
Huh? I did.
Oh, I'm sorry, then I must have, because I thought you wanted to go to 14, you didn't want to go to what they.
No, but he
I-
referenced that discussion before he
I
made his
referenced
motion.
that, but I feel that having 14 maybe is going to occasionally be problematic. Maybe it isn't, but I feel that it was what was originally supported by the Ledge Reg Committee. It's what CPHA supports, and it's what the original sponsors put forth. And so
you're recommending oppose unless amended to change it to?
We have a motion on the floor
I would
right
like
now.
to change my motion.
Oh, you want to change, you want to revise your motion, Albert?
Yeah, I would like to change the motion that they could allow to appoint a tech to the board.
Just a tech.
Just one position.
One position.
Which is,
just
are
a
you
tech.
saying the same thing that Stan
Stan
is?
is
no, he's not.
Yeah,
He's
yeah.
saying
And I just want to make a comment really quick.
Saying the same thing?
That would be 14.
When you look at the legislation up in Sacramento, you have a House of 80 and 40. And they make it work. So FYI.
And I have another point.
Good point, Valerie.
There's another way around this too, is that we could have by policy that the chair, whoever the acting chair is of the board, does not vote except to break a tie. We used to have that policy where the chair did not vote routinely, and the chair would only be involved in a tie. So
Right.
you'd either have an odd number of people and you wouldn't vote there, or if you had a tie, you would come in to break the tie.
Good point.
And if you do that, you can put that in, if you want to really do it as a statute, you can
Good
put it in
idea.
as part of the statute, and you can solve the problem that way.
Good.
Well, I guess
Wait,
I
Laura's
guess
saying
14
no.
will be a good compromise.
So,
I don't think you want to put.
I wouldn't put.
I wouldn't put
put it in
parliamentary
there.
because that's always going to depend on the particular quorum that you have at any particular
but that's
meeting.
part of the, but if that's the deal that keeps the board at a manageable size or a more manageable size, I don't know.
Well,
can make
I'm with
that a-
Valerie in the sense that if you believe you can make an even number work, then you should make it work with your own policies. I don't think you need to have a statute telling you.
Well, that
I
would be an
agree.
example of how we could do it.
My only, can I just ask though, if we've already, or if the bill has already been at 14, has already within the legislature received pushback, that's my only worry, that are we approving something that has, according to Lorianne, the legislature has already said not gonna work. So, I mean, I just don't want us to vote for something that we know we're gonna have problems with.
Well,
can I interject one more time? Based on what we're hearing, and this is what I'm listening, I know we have a lot of interest and so forth, but, we have Albert at the end who has said that he would like to motion to support adding a member from the pharmacy tech at 14, which it's a viable number that we can definitely work with, and it does show the support of that position in the board, which is an integral part of that. We are here not to create the policy because the policy is still being discussed up at the state level. Here's just a letter of support. Do we support this? I would say I would support it with the 14 number and then just move on from there.
I agree.
I think that is the motion that Albert made.
We need a second.
And that's
And
where
I'll
I was
second
trying
that.
to go. I'll
They'll second that.
What's the motion again?
The motion is to support the letter, support this bill with a 14 member, which would include one member of being from the technician.
As it was originally proposed to the legislature.
But that's actually an oppose unless
That's
amended
opposed
position.
unless amended.
That's opposed unless
What I
amended.
was saying.
Support if amended.
Or
Okay, so
support
let's
if
talk
amended.
one at a time so that everybody can hear. So Albert, you've got a motion on the table, which is oppose unless amended for a 14 member with one tech on the, okay. Is there a second to that? You seconded it?
Yeah.
Okay, any public comment?
Yes.
So the original motion was the
Oh, you add.
oppose unless amended, and that would be a tech and a pharmacist be added. That was your
No.
original motion.
No.
That was his
And then you modified your motion.
Oh, yeah.
And
He's
so
doing the same
question
thing as
is
Stan.
Whether or not the second approved that modification.
Because that's
Okay.
what I was saying in the beginning.
Yes.
Okay.
She didn't second it, Laura, until he amended it.
Go ahead and let
Lori.
the public members speak.
Just a brief comment. The Senate Business and Professions Committee did not have an objection to an even number. It was simply their concern with the Supreme Court decision and wanting to add another public member, but they didn't express any concern with a 14-member board.
Thank
Okay,
you.
thank you.
Good, yeah.
It's good to know. All right, so we have a motion and a second. All in
Right.
favor?
Yes.
Opposed?
Oh.
Okay, you're always going to be the odd man out there, Alan. Come on. Okay,
Did somebody?
Greg, let's go on.
Did you get all the votes,
Moving
Laura?
on.
Yes, 910.
Any chance of
Okay.
taking a break?
That's what I was about to say.
Yeah, okay. 5 minutes.
5 minutes? Okay, 5-minute break.
We are beginning. We have a quorum, so I'm going to start. I'm going to take these out of order a little bit. I'm going to go to, and by the way, this group is legislation impacting the practice of pharmacy or the board's jurisdiction, and measures without recommended or current positions. Okay, I'm going to move to AB 401. Which is number 3 in this section on page 8. The measure establishes regulatory framework for telepharmacy. As proposed, this measure would create a remote dispensing site pharmacy that would be staffed by pharmacy technicians with a pharmacist providing supervision and patient counseling service via a telepharmacy system. The model would be limited to use in medically underserved areas. As a committee, we discussed the measure from both a policy perspective and an implementation perspective, noting that the provisions would allow a rural area access to a pharmacist that it may not otherwise have. The committee noted its concerns with proposed expansion of the supervisory duties of a pharmacist and questioned whether appropriate controls are in place to prevent consumer harm. Now, we're not recommending a position on the bill, but think it would be beneficial to discuss the policy as a board. And I'm going to ask Ann to step in here because there's 3 items that we want to consider.
So I think the first thing is, from the policy perspective, how does the board feel about this type of a pharmacy? So it's essentially a pharmacy in a medically underserved area. There are some good protections in this measure in that the intent of the legislation is to bring pharmacy and pharmacist into a rural community. It does it through telepharmacy, as opposed to a physical pharmacist present. And so there are protections in place specific to the controls of the physical building and then how the pharmacist services are going to be provided. And one of the elements that is interesting in this proposal is that it requires consultation on every prescription. And I think that that's how they are supporting getting the pharmacist into the community and making sure that the pharmacist, although not physically present, is present in the community. So there are some interesting things within it. Some of the things that the committee expressed concern with is, under the constructs of this legislation, a pharmacy is a regular pharmacy, and then there's the telepharmacy that's controlled by the technicians. And so there was concern about the relationship and the number of supervisory sites that a pharmacist could be responsible for. So under this bill, that could be 2 sites, and each site could have 2 techs. So there was concern from that perspective, so I wanted to highlight that is one of the construct things that the committee expressed concern with. There are some safeguards in place with respect to the controlled substances, because the drug ordering does happen at this remote location. But with respect to the controlled substances, there are provisions in there that, although they can be ordered, they can't be stocked and everything else until there's a pharmacist present. And then it also requires that there be video cameras to ensure that there is monitoring of the pharmacy operations when a pharmacist is not physically present. And then there's timeframes with which you would need to maintain the video. So one of the things that staff would be recommending is that they extend that period of time, because it's currently 90 days and we think it might need to be longer.
So the one pharmacist, 4 techs, is that something that we're going to have to deal with our tech ratio issues and regulations?
So under this bill, it would be changing what that ratio is.
Yeah, I have
Just by virtue of the way that the bill is constructed, it wouldn't be a policy decision for you anymore because the bill is establishing that. Does that make
Would
sense?
it be changing the ratios for a pharmacist anywhere to now have 4 techs?
No. Just for this.
It's just for the,
For this specific licensing model,
and I have
a supervising pharmacist could have 2 locations that they could be supervising, of which there could be 2 techs in each one.
Yeah,
But it doesn't spill over anywhere else.
Just for the remote.
But it also, there's a provision in here that states that is in addition to the techs that they might be at their physical location as well.
Now, I have 2 questions.
Can I comment on that? Go ahead. But I'd ask to comment on that.
My question number 1 is, does it define, like, since this is supposed to be for rural situations, it does define rural, so.
It's medically underserved.
Medically underserved.
Okay.
Yeah, and I think that we identified when we were looking at, I think there's 115, I think, medically underserved areas.
I think it's actually a defined term that you can actually find where they are.
I don't know, yeah, I don't know that they reference, I think that there was talk about referencing the medically underserved that like the federal law looks at or something. But I think that this is, I think that they're looking at it slightly differently, but.
I know in LA County, which is a very diverse area, there is medically underserved areas. So it could be a urban area.
All right, so question number 2 was, we're not going to be the first state that does this. So other states have already implemented telepharmacy. So have we had an opportunity to compare what has been put in place in other states and maybe what has been effective in other states versus, we don't need to recreate the wheel. So do we?
Yeah, so this is not board-sponsored, but it's my understanding that the proponents of this measure have models in other states, and they have developed this legislation as they believe it will work in California.
Okay, I have a problem with this one. I can tell you right now. The fact that a pharmacist is going to be looking and be responsible for 2 techs on a television, on a screen, and then also be responsible for a tech that's doing work where he is.
Yeah.
And then the fact that, okay, they do it in other states doesn't make me feel good about it, because there are other states that have 5 techs per pharmacist. So I do remember in the meeting, it was a wait to see how this worked out as opposed to supporting this.
Yeah, we didn't take a position.
Also, this underserved area, when it's not underserved area, what we gonna do? Are we gonna take away that?
No, there's a provision that states that should another pharmacy enter the community, this model can continue to operate.
Yeah, so they no longer be underserved. Yeah.
Oh, but
So I mean,
before we go on, what's the physical
I mean,
model here? Have we got a drugstore without a pharmacist?
Yes. The pharmacist is
I have problem with that.
remotely monitoring through the use of cameras and that kind of thing. Is the concept, which is why I suggested that you discuss the policy piece first to see if you're even comfortable with the model, and then if so, then talk about some of the
Well,
details.
I do have it. I mean, if another pharmacy come in and they continue allowed to do that, so that means you have a pharmacy without pharmacists?
That's an issue. So the question is, do we want to take a position on it? 'Cause
I
we
would
didn't
motion to
have a
oppose it.
Motion to oppose.
And I would second.
There's a second, okay. Further board discussion? Public.
So actually, I'm kind of, this is like kind of the future of pharmacy. I would be more comfortable if we opposed with amendments, like maybe make some
I will
suggestions
do
of how to
that.
change it.
I will do that. I will amend that, oppose unless amended that when another pharmacy come in the area, that pharmacy will be required to have a pharmacist.
You still second, Cheryl?
And I actually have a question for Ann. Can we get this definition of medically underserved?
Yes,
Because
it
I know
is.
that most of the county I used to work for was medically
Yeah,
underserved.
a remote dispensing site pharmacy shall only be located in a medically underserved area unless otherwise approved by the board. For purposes of this section, a medically underserved area means a location that does not have a pharmacy that serves the general public within 10 road miles of the remote dispensing site.
That's a lot. This could be quite extensive. Be quite extensive.
10 miles is a pretty small
Yeah.
minimum.
And this is robotics, or is this
It has
just
to be
a
within 10 miles.
telepharmacy
of
means there's a
the
technician working
pharmacist that's
with?
doing.
No, she's talking about if there's no pharmacy within 10 road miles, you can
I
have
don't
a
think
remote
that's what
dispensing
she
site
said.
pharmacy.
Is that what you said?
I think that would take out the urban aspect, wouldn't it?
I think you need to read
Not
it
really.
again.
No, there's a lot of places. 10
Can,
miles.
can you read it again?
Gosh, my glasses. Okay. A remote dispensing site pharmacy shall be located in a medically underserved area unless otherwise approved by the board. For purposes of this section, a medically underserved area means a location that does not have a pharmacy that serves the general public within 10 road miles of the remote dispensing site.
So what I was saying,
10
Greg.
miles of the remote
Whoa.
dispensing site.
Right, so basically you have to be able to draw a circle, and if you have a circle that has a 10-mile radius in which there's no pharmacy that serves the public, you can place a remote dispensing site pharmacy within that circle.
Got it. Oh, that's
You're
kind of
seconding that?
small.
I don't necessarily agree with
The road, it's roads. Yeah, it's actually, it would be, the circle would be different because it's road miles as opposed to crow flies miles. So I was using a rough approximation, but.
And just so-
Is
just
any
so-
of this discussion going to end
Actually,
up
it'd be bigger.
suggesting that we don't oppose this?
Actually,
What is the committee's position?
You're gonna
Didn't
I'm gonna
take a
need this.
position.
You're gonna need it.
Committee didn't take a position, but we do have a motion to oppose. So is any of the discussion going the other direction?
Yeah, question, I don't understand. Telepharmacy could also mean robotics. So a pharmacy is managing a robotics dispensing.
So not in this bill.
This bill is just having a technician working without a pharmacist.
With the pharmacist remotely monitoring them
monitor.
via telepharmacy system.
The pharmacy without a pharmacist.
So there's no technology. Okay, got it. And when I say technology, that
I would
that does
like to withdraw
control.
my motion.
I would make a motion, we support it.
You
Support the
support-
bill?
Wait, we already have a motion
Have a
on the
motion to
floor. Oh, we
oppose.
don't, we don't.
Okay, can we
He
just
withdrew
talk?
it?
Okay, I'm gonna use my gavel. Can we talk one at a time? Because it's really hard to hear over. Okay, so we have a motion.
To support.
No, you already
Oppose.
have a motion.
To oppose.
No, he
He
withdrew his
withdrew.
motion, Debbie. He withdrew his motion.
I thought I had second, or?
Well, he withdrew his motion. So you with your,
Do your motion, Albert?
So your second doesn't apply.
We're gonna oppose it?
so Stan, what is your motion?
My motion is
Gonna
to
oppose
support.
to support.
Support the telepharmacy bill.
Right.
I'll second it.
Second, Debbie?
Debbie.
Okay, so you're supporting the bill.
We have 13 pharmacy schools in the state, and we have 4,000 new licensees every year. If you would identify what are the underserved area, and you tell these pharmacists, they're going to plenty of them will willing to open a pharmacy just right there. We're different than other states. Other states could be very remote, but in California, you do really have an oversupply of pharmacists right now.
And I
So by-
understand,
by
I
supporting
understand
the
that totally.
telepharmacy bill, I mean,
Some of these rural areas have 462 people there, and nobody is going to open up a pharmacy with 462
Right.
people. And so I can see a small remote pharmacy with 2 techs and a pharmacist supervising by way of video. And I mean, we're talking about underserved areas where there's probably no physician and no pharmacy and and I can't believe that a pharmacy or a pharmacist would go there because
Economically,
the
it won't
population
work.
is so small.
Yeah.
Now that's my druggist view.
Okay.
Albert.
Stan, but the way they word it, if Walgreens open in the future there, that pharmacy considered allowed to be continue to serve the same way without pharmacists.
I don't know if it goes backwards, but it seems that according to
I don't think Walgreens would open there.
it seems according to our attorneys that at the beginning, if there's no pharmacy within 10 road miles, then you can open up one of these deals. I don't know if suddenly within 10 road miles a pharmacy comes in, does that suddenly negate this pharmacy's license?
Well, not automatically. I think it would be an issue at renewal, perhaps. But
Turn your microphone on.
For board.
It
It
allows to
specifically
continue.
states that they can continue to operate.
So, Stan, unless you amend it when another pharmacy come in, that they require to have a pharmacist on that satellite.
You know,
Okay, so we
frankly,
have
if
we
another
have a
pharmacy
motion.
comes in, people are going to go there. They're not going to go to the remote one anyway.
As
I agree
Albert
with you.
has said many times.
Yeah, I agree with you.
They're going to go where they can get a real
the
live
market will
person
take
to
care of
talk
it.
to and so
Yeah.
on and so forth.
We have a motion and we have a second.
Right.
Okay, public to support this, any public comment? Good afternoon.
Hi, I'm Gary Cacciatore. I'm Vice President of Regulatory Affairs for Cardinal Health. We are sponsoring this legislation. Happy to answer any questions you have. But the main point I want to make is this bill is really about access. And it's providing access to patients who don't have pharmacy services. They don't have dispensing services, so they're not taking their medications. They're not adherents. So they're going into the hospital when they shouldn't go into the hospital. So we're trying to get access to a pharmacist, to the drug itself, and then because this bill requires consultation on every prescription, the consultation is provided via technology. Technology has advanced a lot. The telepharmacy has been around for a long time, but what's changed is the technology has changed. It's gotten cheaper to do. So and the studies have shown that it's just as safe having a pharmacist review this remotely. Everything is recorded. Everything is barcoded. Everything is the pharmacist sees everything that they would see as if they were standing next to that technician. There's been no change in medication errors with telepharmacy. Many states are looking at this. And if this board is about protecting the public health and giving people access to medication, this is something I think the board should support. But
Now, can you give us, just create a picture of what this would look like for the board members?
yeah, so I mean, there's different models in different states. This particular bill, it would be, as you said, it will look like a pharmacy. It's staffed by a technician. Drugs are stocked there. Patients come in, they drop off their prescription. The prescription is filled by the technician. There's a camera over the entire dispensing area. There's also video cameras of the entire pharmacy for security purposes. But the entire dispensing process is captured on video and is stored in forward technology. So the filling process is reviewed by a pharmacist at the supervising pharmacy. The medication is checked, make sure it's the right medication. The order entry is checked just like it's checked there. So it's
Can I interrupt you just
technology,
for a
as you
sec?
said, but it's not a remote dispensing machine.
Okay, so I think one of the concerns is that there could be potentially four technicians to one pharmacist. And it's the supervising pharmacist back at the mothership. So that supervising pharmacist back at the mothership, I mean, their job is to manage these four technicians, or is their job possibly to run the mothership and then occasionally look in on these four technicians?
It can go into a queue so it doesn't interrupt their normal workflow at the other pharmacy. So that they'll know something's up at the telepharmacy for them to review the process. So it won't be a live process, but they can see everything that was filled, and nothing goes out of that telepharmacy until it's been approved by the pharmacist.
Would that pharmacist at the mothership be supervising pharmacists there too?
Under the bill as written, they could, obviously, but it depends on the operation. What we found is that small towns have lost pharmacies, and there's nobody to replace those pharmacies. So what we found is a lot of our customers, economically, they can't open a pharmacy in the next small town over because they can't pay for a pharmacist there. So this just gives them the option that they might be able to do it because economically it's more feasible to do that. And as to the issue about if another pharmacy opens in that area, that's not likely to happen because if that area these telepharmacies do very little volume, so it's not economically feasible to put a full service pharmacy with a pharmacist within that area. So I don't think that's really much of a concern.
Whatever pharmacist elects to take a job like that would understand all of the responsibilities and the oversight. So they would already go in there knowing
And
that's what they would be doing.
Are these rural areas or urban areas that are underserved?
Well, as defined in the bill, it's an area that doesn't have access to within a remote site within 10 road miles. Because what we found is not just economic issues, there's transportation issues. So asking somebody to go 20 miles back and forth to get their drug, they may not have the capability to get there without public transportation. So it's written as a way to define it as 10 miles being a reasonable distance that people would go to and can actually have access to
The difference, Debbie, is that the medically underserved has a definition. However, this bill seems to have a different definition. That was what the confusion, because there is a medically underserved defined term. This is different, just 10 miles.
Right.
And in my view, this far surpasses an automatic dispensing machine with a telephone booth next to it.
Albert.
Well, you say one pharmacist could operate 2 locations, 2 satellites. So you got a pharmacist controlling 2 pharmacy tech in his own pharmacy, and 2 other tech at 2 other locations, a total 6 technicians he have to under control. And that's number one. Number two, like Victor said, we got a lot of new graduate pharmacists. Just like one of my technician, I say in the future, by the time you become pharmacist, there's no job around. He said, well, I have to go to a rural area. And this is true. I mean, the rural area is the opportunity for them. But if we allow this to happen, what preventing the chain for having a pharmacy, cell life pharmacy in the 10-mile radius, and even the population grow, they're not going to open our pharmacy there. They continue to run as a cell life pharmacy.
Keep in mind the volume is going to be very low out in that underserved area. So,
Yeah. So
if
when
they,
they
if
grow,
they're doing it by remote,
Yeah.
It shouldn't impact their activity at their location where they're at by that much. If you have 500 people in an area, how many are going to be in the pharmacy?
Well,
at
I
any
think it
given
makes
point?
a difference as to what is happening at the location where the pharmacist is. When he's
True, if he- if
possibly
he's-
has an intern, he can have 2 or 3 clerks there, intern and a tech. And now he's also responsible for 2 techs in 2 other locations.
So there's no incentive for the chain to have a cell life pharmacy there, and even when it get busy, they're gonna continue to operate the same way without hiring a pharmacist.
Anyway,
Can
I
I
think we have
give you
another
some
public
real
comment.
life
Yeah, we need
experience?
to- yeah, we have-
So part of my time is I live in a community called Fall River Mills. Anybody hear of it?
Nope.
No? Because there's only 250 people that live there. And a mile down the road is another town called MacArthur, 250 people. Our closest town is Bernie, which is 18 miles away.
Haven't heard of that either.
You haven't? So, and then the closest town the other direction is about 30 miles, and that's it's just below Alturas. No one's heard of Alturas.
But is this California?
It is. It's you go to Redding and turn right on 299, and you go an hour and a half, and then you head toward Oregon. Okay, so it's rural because and I happen to one of my fraternity brothers actually owned a pharmacy there, and died with cancer, and unfortunately the pharmacy no one would service the pharmacy. It closed. We have a very small hospital. I sat on the hospital board. The hospital could not support the pharmacy needs, and people knowing that I lived up there part time would constantly ask me, to become a pharmacist. So I think there's great need to it. I guess my concern is that Cardinal is sponsoring it, so I see a revenue generating side over here that bothers me a little bit. But I think there's a need. Even our hospital there, we have one pharmacist that lives in town, and he is the quality control pharmacist for the hospital. He does kind of medical director for the hospital, everything. It's a one-horse operation. And so he can't be there 24/7. We have a Pyxis machine, and we contract with the pharmacist in Ohio. So in the middle of the night, when a doctor writes an order, that order is the pharmacist in Ohio has a contract to read the physician orders, and then says, okay, nurse, you can go ahead and use that. There's no allergy, there's no contraindications. And so that's how we manage having a pharmacist at the hospital 7/24. It's all done by remote. And we're doing a lot of remote telediagnosing too, because the practitioners are very limited there, as you can imagine. So I see the need for it. I have my concerns, though. I mean, I think I could see it better if it was one of these machines that, you can computerize into it, it'll label, drop the bottle off and vial, instead of having an array of inventory sitting in a closet with a technician. That worries me a little bit because that's all open. And trust me, these rural areas do have massive drug problems on the abuse side. So they have both. They have the need to have service, but they also have that potential. And I'm afraid that if you had a pharmacy up there that was pharmacy without some sort of oversight, you were going to have problems.
Yeah. I can see a telepharmacy. I'm not completely opposed to it. I'm just opposed to the fact of a pharmacist being somewhere where they're responsible for clerks and techs, interns, and then looking at a TV monitor to also be responsible for 2 people at both those locations. And when we see cases where we see pharmacists losing their license because of what a tech did, and they lose their license after 6 years, that's my concern.
Thank you
I have the
both.
same. Pardon me?
Thank you.
Thank you.
You want to call for the vote? Or no, we have a motion.
Any more public comment?
Do we get a second to
We have
Stan's?
a
Oh,
sec-
Debbie, okay.
Okay, all those in favor of supporting
Support the
supporting
bill.
AB 401, raise your hands. All those opposed? Abstentions? It passes. Thank you. I'm going on to AB 528. SB 528, I'm sorry. On to SB 528, which is on page 11, number 12. Measure would allow a pharmacy to provide pharmacy services to outpatients in an entity covered under Section 340B through the use of an automated drug dispensing system under specified conditions. As amended, the measure details the conditions that must be met to use the ADDS in a clinic where the prescription is dispensed via the ADDS but is handed to the patient by a healthcare provider. Patient consultation would be provided via a telecommunications link that has two-way audio and video. Greater detail to include, that's a recommendation. Okay. Senate, it's in the Senate Appropriations Committee, hearing scheduled for May 8th, and Ann would like to say a few words about this before the sponsor comes up.
A couple of things to consider is whether or not a license should be required. I did look at some of the questions that you've been considering in terms of use of ADDSs in general, the bigger picture that you've been discussing. And one of the questions that you've been contemplating is whether or not you should require a healthcare professional to provide the medication. So I want to let you know this measure does that. One of the questions that you've been looking at is how you're going to ensure the control of the machine. So under the proposal, it allows for either a biosensor or password. I've heard some of you express concern with security, so you may want to look at whether or not a password would be sufficient, or if you want to specify something more. The other thing, yeah, and then the other thing is, yesterday when you were speaking about the provisions of the ADDS and the removable pockets, one of the nuances that council brought up was that although they can be done at the pharmacy and sent over tamper evident, it needs to be someone that's authorized to administer medications, would be restocking the machine at that site, and that specific provision is not in the measure as I read it.
Board comment before public comment? We have the sponsor here, so let's hear from him.
Thank you. I'm Kevin Rue with IMGRX, and we are the sponsor of the bill. And I thank you for your time and your consideration. And in response to the comments that Ann just made, and any board concerns over the identification of the patient, I would remind the board that the language says that the drug is provided to the patient by a medical professional.
Yeah, it was not the identity of the patient, the staff people that are accessing the device.
Okay, well, it is, and actually that's a point of clarification that I have to admit that I want to make with the Legislative Council. When I worked with Legislative Council to craft this bill, there was a heavy reliance upon existing provisions in California law, particularly 4186, which clinics don't seem to make use of, and 4119.1. And in particular, 4186, which is the provision that says that a clinic can do these things, and really our bill is to say that a pharmacy can do these things. That's the crux of it. But 4186 says that the medication is provided to the patient by a professional licensed under this division, and as I reread that in the last week, I realized that I need to make sure what this division refers to, and I'm not quite sure. It is our intention, at least for the foreseeable future, that our machine would have a licensed technician standing by. But I have to admit that if things progress in the future so that we can train the staff at one of these centers and yet still be responsible for the machine, I mean, that's an option we would love to have, is to be able to train a person who's licensed under whatever that division that is that the law refers to. The other 2 points you made, Ann, were
should be required as part of it because it doesn't currently
True.
have the license piece. And then with respect to biometrics, the biocenter versus a password, and then who's going to stock it at the 340B. So you just said a tech, but it doesn't necessarily say that, I don't think, in here.
Well, yeah, for stocking, we specifically went back to that really confusing statute of 1216.
Missing is that there's a provision, I believe, in the 1261.6 that says that it can be filled, but it has to be, one, consistent with the policies and procedures, but also by someone that's authorized to administer medications. And I think that piece is the one that's missing.
Yeah. Well, I can say that the stocking, it's our intention that we want it to be done by a technician. So the under the supervision of the pharmacist. I don't really see us changing that or practice to make it a non-pharmacy licensed person. And then I guess I was speaking to the identity of the patient when with the biosensors versus ID. We're going to have a person there to verify, because it's a medical professional handing them the prescription, that person can check the ID. And Stan just left the room, but in the prior conversation, Stan stated that he thinks that the telepharmacy model is superior to having the machine, and I would beg to differ in that in the telepharmacy model, the pharmacist, as everyone noted, is looking at a camera, looking at the shoulders of a human being performing the work. And in our model, it is the pharmacist, through the machine, initiating every step of the dispensing process. So we think that we're actually a safer, more secure method that is less prone to error.
So just a question, the 340B aspects, I mean, it could be available to anything, not just 340B. Is there a reason why that was included in there?
That's our market, is 340B clinics, and it is not to confuse terminology with what we just talked about. It's an underserved community generally. 340B clinics and hospitals are often in rural areas, not necessarily though. They are facilities that generally serve poor populations.
No, I'm very familiar with 340B.
Yeah, of course, I know you are.
And
yes.
I would beg to differ that it's in rural areas. There's actually quite urban areas. There's
Yeah, I
a lot
said
of
they can
340B.
be. Yeah. All of ours are in rural areas. In fact, some areas that we really have, even here in California, that we have difficulty hiring a pharmacist to go to. And these are lovely towns that you would think that anybody would want to go to, but we have difficulty hiring into some areas of California.
Question for Ann, in this bill, it would be all devices, it's not to a particular vendor? Correct?
Correct, it is not.
And then
It's technology neutral.
Technology neutral. And secondly, the refilling of the device and everything would fall under whatever our laws are, or our regulations are?
Yeah, so I think that we can maybe work offline to kind of address maybe that piece of it if the board is okay with that.
Happy to.
Yeah. No, because I think I actually thought I saw the demo, and my concern was having a wholesaler restock a machine. I had a lot of concerns with that.
You've made reference to that a couple of times in meetings since that demo, and that was, I'll confess, an early dream of ours.
Okay.
That
So it's no longer that.
It is no longer
Perfect.
that.
Okay. Great, thank you.
You're welcome. Thank you.
Thank you.
And what's the committee's position?
We didn't take one.
They didn't have one.
We don't have one at this point, but we do think that there should be a license required.
So if we want the license, should we say oppose unless amended? So we can add in the license requirement?
Apparently. Oh, well, support if amended.
I thought I was on, sorry. Normally, I would recommend an OUA on a position as critical to where the board's going as this. The author of the bill is Senator Stone, who holds several other bills that we are using him as the author for.
Right.
My advice would be to work with the senator to get the amendments we need, and I'm sure that that would be possible without taking an OUA.
So we don't take.
I'd
any
say
position
support if
today.
amended.
Support if amended.
Or support if amended.
Yeah,
Just-
support if amended, I
Okay,
think is the way to go.
I so move.
Okay, second?
I'll second.
Okay, any other discussion by the board? Public? All those in favor? Unanimous, without stand.
All right, you're on a roll.
All right, I'm rolling. All right, so, yeah, the rest of these bills in this section do not require any action. So I would say if there's anybody that wants to discuss any of them, let me know now or forever hold your peace.
Well, I guess can you just, AB 1589, the technician, because I know at our licensing committee, there was quite a bit of discussion, on the future of technicians, but also came up that, a couple things, that it had been a while since we had looked at technicians and made any modifications, and that there was probably a need to look at the ratio. And it looks like this would require like a review of the ratio on a more regular basis, so we don't find ourselves kind of in the situation we are. I know that there was at one point, I don't know if it still is, some sort of, there was a fiscal impact. Was there some sort of a survey?
It requires the board to convene meetings and then to make a report. So it requires us to research and then report on what our findings are and whether or not we make any recommendations on whether or not there should be a change to the ratio.
So could those be as part of like a licensing committee meeting?
It could be. I think it probably would depend on what the agendas are.
Probably don't need legislation to do it, right?
I'm sorry, I didn't hear.
Probably don't need legislation to do it. And at licensing, you could say, well, talk about ratios and decide you want to change.
So is that why the committee didn't want to do anything, because they felt like it was a bill that wasn't, it was regulation that wasn't needed or statute that wasn't needed?
I don't recall exactly why the committee did that, but I think that was certainly one of the arguments. Okay.
I mean,
We should ask Laura or Josh, maybe you could answer the question. If we need to change the technician ratios, does that need a statutory change or just a policy change?
oh, it's a statute.
It's a statute.
Statute?
Yeah, that's a statute, but I think this, so this bill just kind of causes the board to, on a regular basis, look at it.
Right. It creates a mandate on us. And the one thing about a mandate is that generally, if you need staff, you can put resources on it. So that is one of the things that we would be doing, is putting a half-time staff person on it to do the work.
Yeah, I think that was the other reason, is the sources and the fiscal issue. That'd be I don't know.
I mean, I don't know. I mean, I don't know if anybody else on the licensing committee feels, I mean, I tend to be one who, I don't like to overregulate. So if we feel like this is duplicative and that it's not adding anything to what we already do, other than we need to make sure we've done a poor job up to this date. So
you just need, whoever is chair of the licensing committee.
I mean, I think that's the board and the president. I mean, this is beyond our lives, but so I just think we just have to
Give it back to licensing, have them watch the bill at least, or talk about how they could do it in the event the bill doesn't go, if that's something the board ultimately decides it wishes to pursue as a course of action.
So
I think that licensees are already kind of going down that path. I think we kind of decided not to talk about ratios because of this bill at our summit, but
Yeah.
I think it's going to come up.
Well, it will come up, we know that, but it is kind of, it's not the first tier for the board, I don't think, because it is an employer-employee relationship as long as it doesn't become unsafe for the public. And that's where we would have to make some judgment call, I would think.
But I'm hearing that the staff's analysis is this is probably regulation we don't need, as long as
That's what I'm hearing.
as long as the board.
There were several provisions that the committee reviewed where they were like, I don't know that I'm necessarily opposed to the policy that's being put.
Alan, that's cool.
Alan.
There were
think that
several
might be
pieces
Victor.
of legislation that the committee heard where they felt that
Alan.
they were not opposed to the policy. They were not in support of the policy, but it was like, this is really just what you should be doing as a regulator. This is just good government. Do you need a mandate to do it? So a lot of the discussion with the committee on several provisions was specific to that. Do we really need a mandate?
Okay.
So, are we
I don't feel
moving on?
moved, no.
Okay.
And are there other bills we need to look at?
Are there any other ones that need discussion?
No?
Okay. We'll move on to regulations. And Ann is chomping at the bit to do the summary, so I'm going to let her do it.
There's just been a couple of updates since the chair report was done. So one is specific to the travel medications, and we just want to let the board know that that is now, the package was resubmitted to the Office of Administrative Law on April 26th. So it will be going through its review. We did ask for an immediate effective date, assuming approval from OAL. So those provisions would take effect upon approval.
That's the end of 493, right?
That is the end.
That's the last one pending. Good.
Disciplinary guidelines, which was, we had to resubmit following disapproval, that is under review by the department fairly recently, just submitted it recently. And I think there were several that we submitted for pre-review where concerns have been identified by the department, so we need to be working with them to address their concerns so that we can move forward with those. And then the last one is the offsite storage waiver changes. That regulation package was submitted to the department for pre-review. Those are the updates from the chair report.
Okay. Do we have any board comments on that? Any public? Okay. That concludes the legislation regulation report.
Yay.
All right, so now we will move into closed session. So we'll adjourn to closed session, and then we'll reopen for open session. This actually is a conclusion. We open for back into open session. There will be no other open business, so I just want to alert those that may be waiting. There will not